the past for giving us this opportunity. So I just wanted to extend my thanks to the incumbent team of NSOG, the current team and the past team for giving me this privilege to conduct this simulation workshop in the city of Nashik. Yes, I have been here several times in the past on the anesthesia side, and I was in Fox in 2014 also. So basically what is simulation, why are we here today? Again greetings from Nashik. Basically, if you look at the practices in medicine have changed and there is a paradigm shift in the way we manage. There is a paucity of patients and you know the work hours and the time limits week on week they are reducing. And how do we upgrade the skills of clinicians is what is always worries the people who have done medicine in the past, and the simulation came as a blessing in disguise. So basically simulation is a very valuable tool. It helps us in doing procedural skills. Importantly, it also helps us to reduce errors. Like if you do same thing repeatedly, again and again, you gain perfection. That's what the simulation is meant for. So basically, it helps in upgradation of the skills, and importantly, it enhances the perioperative peripartum outcomes. More importantly, the medical decision making, the algorithmic approach, and the team approach is what we encourage. Conventionally, a simulation, if you see, it also teaches us the soft skills. Like when you have a crisis, we see especially, I still recall an episode from long back when I was working as a registrar at Apollo Hospital immediately after my MD. The cardiac surgeon said if we are doing 5 CABGs, everything goes silently, but once cesarean section, the entire theatre knows. So there is a noise there. The cry of the baby or the hangama, the start cesarean section, the fetal distress, so many things happen. So the noise levels are very important, and during this crisis management, how do we increase our soft skills? The soft skills are basically nothing but the non-technical skills, the communication skills, the listening skills, the inter-team discipline, intra-team discipline is what this simulation teaches us. And importantly, crucially, the time management, because our pregnant patients are phenomenally stable. Like obstetrics, if you ask me in one line, it is terribly simple or simply terrible. And we have seen both sides of coin day in and day out. So what we intend to do during today is call a few delegates to do the simulation. We will present a brief case history, and basically this simulation is simulating is a sim mom. She is a pregnant mother. You can perform cesarean section, you can perform delivery, and she can talk to you whatever questions you want to ask, whatever history taking you want to do, and you can manage as if you try to do as if you are doing in the real life. The only thing is the days will be limited to minutes because we need to accumulate 4 or 5 scenarios today. Conventionally, a single simulation runs with 4 to 5 delegates for an entire day. One scenario, 4 or 5 delegates, entire day. And here we are trying to accumulate 5 scenarios, 50 delegates in 3 hours. So, but anyway, we'll try to convey the best possible things. We expect the delegates to do errors. There's nothing wrong, and we'll run the same video again, do the debriefing. At the end of every scenario, we'll discuss the evidence-based current guidelines in the management of those crisis situations. So, if you look at acute metal collapse, this is what the crisis management is. We have devised this acronym ABCDEUPS, and we know that if you follow these algorithms, you can 99.9% of all the etiological causes you can incorporate. Like A stands for anaphylaxis, anesthetic causes. Your anesthetist is very well versed with ruling out their causes of crisis management. But importantly, B is bleeding. We know bleeding is the leading cause of mental death in our country. C is the cardiac causes of metal perioperative or peripartum crisis like cardiomyopathies or diagnostic stenosis. Unrecognized. Recognized is we are all prepared. When the parturient comes is unrecognized low cardiac output syndrome, and suddenly after spinal she crashes and you attribute it to spinal, but she may be having optic cardiomyopathy. So how do you manage those things? And drugs. Medication errors are the leading cause of mortality worldwide. And we have seen several cases of tranexamic acid injected inadvertently intrathecally, and medication errors per se or medicines per se also can cause death because of anaphylaxis, because of magnesium toxicity, like we see nicer toxicity. So drugs are an important cause of perioperative crisis. Oxytocin can cause severe drop in SVR and can cause profound hypotension, especially with underlying heart diseases. So, and E stands for eclampsia, the entire spectrum of hypertensive disorders, right from pre-eclampsia without severe features to pre-eclampsia with severe features, chronic hypertension, PFL complex, postpartum pre-eclampsia, and even peripartum hypertensive cardiomyopathy. Use uterine causes, like most of the time it's atonic PK, leading cause, 4 T's we know, but we have added the 5th T. We'll discuss about 5th T a little later. But yes, the abruption, the coagulates, the ruptures, the uterine placenta spectrum, which is increasing day by day. And P is the pulmonary causes, pulmonary embolism, amniotic embolism, or eclampsia, obstetrical embolic disorders. And S is for sepsis, which is again the third leading cause of fetal mortality. So hypertension, hemorrhage, sepsis, if we conquer these three diseases, which can be anticipated, which can be proactively anticipated, treated, you can bring down the MMR to less than 24 lakh childbirth. So basically that's the focus. And the goals of resuscitation, if you see, are the maternal as well as fetal. Being an obstetrician, our aim is to give best to both the lives. We know that if the neonate of the fetus spends a day more in the mother's womb, 1 week stay in NICU can be reduced. So as an obstetrician, we want to prolong the pregnancy as much as possible. As an intensivist, we want to give best to the mother, to the fetus, not to the extent of fetus, like just to make the fetus survive or to wait for steroid this thing and wait for 2 months of compromising mothers. So that should not happen. So basically, we need to look at the maternal physiology, we need to look at the fetal physiology, the 1 fetus or 2 fetuses or 3 fetuses depending on the multiple gestations. But importantly, simultaneous assessment and management has to go hand in hand and see that you optimize the mother before we deliver. So we want to give best to both the lives without compromising. And we know the cause of fetal demise. There are 3 important causes of fetal demise: severe drop in maternal blood pressure, severe drop in hemoglobin, and severe drop in oxygenation. So hypoxemia, hypotension, and hemorrhage are the lethal threat of fetal demise. And if we resuscitate these 3 causes in the mother, the fetus automatically gets stabilized. So basically, this was in brief. But if you want me to go through the different causes of collapse in detail, where anaphylaxis can be many drugs, anything under sun, including sun, can be allergic and cause allergic reaction. And we know that intraoperative or perioperative, right from anesthetic agents to obstetric uterotonics to ondansetron to proton pump inhibitors to H2 blockers, latex, anything can cause allergy. And we need to have an eye to pick up. Not every allergic reaction or anaphylaxis can cause rash. Many times they present just with bronchospasm, some of them they present just with vasodilatation and profound hypotension. And only one thing that you have to remember is, any crisis, any collapse, only 3 things are important. ABCs. Airway, breathing, circulation, stabilize it. And if you cannot, if the mother has cardiac arrest, then CAB, chest compressions, airway, breathing, and circulation, and you need to do ABC thoroughly. I must tell you that pregnant mothers have a poor reserve. In fact, they have an enormous physiological reserve, and they don't have the classic telltale signs. Suppose if the non-pregnant patient has class 3 hemorrhage, you can pick up very early. But pregnant mother, because of the plasma expansion by 50%, the telltale signs, they do not come early. But the moment they exhibit those telltale signs, they collapse suddenly because they don't have the extra reserve. Like if you look at the cardiovascular reserves, the patient has already, the body output is increased by 15%, almost about 30 to 40%. 17, 14 liters is what we see, unlike 5 liters, 6 liters in a non-pregnant patient. And for the stress, already myocardium is stressed out, so they go into decompensation very early. Similarly, renal composition. Like if you look at the respiratory system, the minute ventilation increases by almost 50%. So there is respiratory alkalosis. In order to compensate the respiratory alkalosis, the kidney loses out bicarbonate. So if you see the normal ABG, every pregnant mother, you need to remember that ABG in pregnancy is different from ABG in non-pregnancy. The normal PaCO2 in you and me, I rule out the pregnant mothers here. the normal PaCO2 is 38 to 45 millimeters of mercury in non-pregnancy. In pregnancy, it's 28 to 32. That is a respiratory alcoholic state. If you see PaCO2 of 35 in pregnancy, it is impending respiratory failure, and PaCO2 of 40 is respiratory failure. So you need to remember this. Similarly, pregnancy is a state of hyperoxia, because it has to take care of the features also. The PaO2, the arterial oxygen concentration tension is about 95 to 105 millimeters of mercury. In non-pregnancy, is about 80 to 85 or 90 millimeters of mercury. So, pregnancy, they desaturate rapidly, and we need to maintain little high oxygen concentration targets. And because the kidney is already conserving the acid and bicarbs are being lost, the normal bicarb in pregnancy is 18 to 22. So already mother is little acidotic, -6 to -7 already is normal physiological change in pregnancy. So if there is an additional insult in terms of hypotension, in terms of sepsis, the metabolic acidosis ensues very rapidly. The pH drops to 7.1 very easily. And similarly, we all know that pregnancy-induced causes, AFLPs, HELLs, and amniotic embolism, the prothrombotic state, the microcirculation is impaired, oncotic pressures are low, and they decompensate very rapidly. And of course, risk of aspiration. One of the take-home from this slide is never undermine the importance of ABG in a sick mother. This was a patient on the right-hand side. You can see the slide, right? Yeah, on the right-hand side, you can see our student comes with severe preeclampsia with severe features, pulmonary edema, pH of 7.1. Can you appreciate that? 7.0 rather, at 10 p.m. in the night, and we stabilize and deliver her by 11 p.m. or midnight, and at 7 a.m. in the morning, you can see the pH coming back to normal. And this is the beauty of pregnancy. Suppose if you miss out that window of 7.0, the mother goes, like this patient was preeclampsia profile was completely normal. So preeclampsia with severe features like acute imminent acute kidney injury. So if you miss out this window of resuscitation and optimization and delivery, they go into acute tubular necrosis, acute kidney injury, and then patient lands on dialysis. So you need to remember that blood gas is a very important probe. So any preeclampsia with oliguria, do a blood gas. And because from an anesthetic viewpoint also, very important. Very frequently seen complication during delivery, massive hemorrhage. Each one of us must have encountered with acritas and incretas, but never allow hemoglobin to drop to critical levels. We'll discuss more on this when we come to scenario. But do not allow hemoglobin to fall below 6 grams. Raise the transfusion triggers early, and endpoints of transfusion triggers should be defined. And develop a skill of compressing the aorta manually. And this is what is the manual compression of aorta. Not everybody is well versed in putting clamp on the aorta, especially when you have a catastrophic hemorrhage because of acritas, incretas, you are not able to control. Put a manual compression. Change the anesthetist very well knows. Just have to compress aorta. In fact, Osaka has a series of more than 100 cases in Fernandez Hospital where they have used this life-saving device. We use mostly the vascular clamp because our surgeons are well versed. Just clamp common clamp aorta, and you can control the hemorrhage. It's a life-threatening hemorrhage, but life can be saved. So these are the skills that you need to master it, because we know that massive hemorrhage can lead to lethal triad, and massive transfusion can lead to lethal quad. Coagulopathy, acidosis, hypothermia, and hypocalcemia. So we need to prevent this. So the patient, we should not allow the patient to go into this triad of acidosis, coagulopathy, and hypothermia, because they are all interconnected. Each one worsens everything. And when you are giving massive transfusion, like more than 6 to 8 liters of blood and blood components, they are going to citric toxicity and hypocalcemia also. And believe me, the citric toxicity or massive hypocalcemia can ensue early if the patient has PPH or hemorrhage in AFLP, hepatitis, jaundice, and HELLP syndrome, because liver already is not functioning appropriately, because the citrate gets converted to bicarb in the liver. And the liver is not functioning optimally, they go into this lethal quad. So this is the approach that we have put up in our hospital, the 10 commandment approach in massive obstetric hemorrhage. We'll come to it in more detail, but more importantly, maintaining circulation, having a multidisciplinary team, calculating allowable blood loss, quantification of blood loss, not calculation or estimation of blood loss, it's quantification of blood loss is important. Resuscitation, fluid resuscitation, blood and blood component resuscitation, little bit of physiology, why patient needs such micro hemostasis. Hemostasis is a microcirculation. Otherwise, because sometimes you see there is no bleed, but patient still is oozing. So hemostasis is the microcirculation level is also important. And how do you monitor? How do you follow? And communication skills, communication consent, documentation, all are important. So basically, other thing which I want to tell you is epigastric pain. As an obstetrician, we always think it is eclampsia, stretch of Gleason's capsule around the liver or subcapsular bleed, but sometimes it can be acute pancreatitis. You can see this fatty necrosis in the peritoneal cavity, and you can see acute pancreatitis complicating pregnancy. So, persistent epigastric pain, do not ignore causes beyond gastritis, beyond eminent eclampsia. It could be pancreatitis. You just have to send MRIs like this, and massive liver hematomas, hepatic bleeds, you just have to keep in mind. The sickle cell crisis, if you look at the hemolysis like HELLP syndrome, you have LDLA, you have LDH is elevated, the bilirubin is more, and you have a combination of thrombocytopenia. But if you see malaria, infective hepatitis, hepatitis A, hepatitis E, leptospirosis, typhus, everything can cause this picture. So as a clinician, you involve your anesthesia team, you involve your intensivist team early so that they can pick up these non-obstetric causes which mimic HELLP syndrome and be picked up early, because malaria can be treated, leptospirosis can be treated, scrub typhus can be treated. You don't have to terminate the pregnancy, but if it is HELLP to FLT, you have to terminate the pregnancy. So HELLP and FLT, you are well versed with diagnosing, and other things, your other colleagues. So involve a multidisciplinary team. This was the case of sickle cell crisis that came as HELLP syndrome, with HELLP syndrome, and we need to have differential, because as a clinician our idea is to identify the black sheep amongst the normal looking sheep. Sepsis is another important cause that you have to remember, and the punch mantra of sepsis is very, very important. Identify early, send lactates, send cultures, give antibiotics, start fluids, start vasopressors or anatropes, and important sixth cause, terminate the pregnancy if that is a cause, like polyaminitis or pelvic sepsis. So Panchamantra of sepsis are very, very important. Similarly, Panchamantra of cardiovascular disease. 5 diseases are very important. The pentad of cardiac diseases that can cause brittle mortality. Tight mitral stenosis, tight aortic stenosis, ejection fraction less than 45%. Marfan syndrome, where aortic dilatation is more than 4.5 centimeters, and pulmonary hypertension is primary or secondary. So these are 5 pentad of cardiac diseases which are very important as an obstetrician, as an anesthetist, as an intensivist, because we know that when we have any of these things, only 5 things are important. Again, 5 Panchamantra of sepsis, Panchamantra of pentad of cardiac diseases. When you have cardiac diseases, 5 things that has to be taken care of: preload, afterload, rate, rhythm, contractility. So if I am giving oxytocin, what is the effect of oxytocin on rate? What is the effect of oxytocin on rhythm? What is the effect of oxytocin on contractility? If you understand those, like if I am giving carboprost, should I give carboprost, should I give misoprostol, should I give any of those medications? What is the effect of all these medications on these 5 things, and try to optimize the situation? It becomes terribly simple to manage these cases. Yeah. And lastly, the metal cardiac arrest. Yes, this is a very dreadful scenario, not very common fortunately, but when it occurs, our idea, 65% of metal cardiac arrest revive can survive. You can revive the mother as you revive the baby. If you look at the chance of successful CPR and successful neurological outcome, mother is almost 68, close to 68% worldwide. Our center is almost about the same number. We have had 12 perinatal cesarean deliveries last 27 years. But importantly, you need to act. Time is crucial, and 4 minutes is the what is important. This was the guideline that we published last year as a task force guidelines from EOA. Our Indian experience basically is available on the Google free, you can download freely. But importantly, we have done little differently from what the conventional European guidelines are there. It can go, we'll discuss it more into details, but importantly, 4-minute code. Deliver the baby at the site of cardiac arrest if it is a pregnancy of beyond 20 weeks of gestation. And do not transfer the patient to theatre. There is no need for consent. You just have to do and-send delivery. And we know it's a team effort. You can't do all alone. And when it comes, it's a high stress situation, and only as a team you can succeed. Again, being from anesthesia background, we cannot recognize the management of pain and stress, which go hand in hand. And Importantly, co-ICU admissions. Sick mother, the baby is also sick. And there is a difference where obstetric critical period makes a difference. If you go with the mother, pregnant mother is admitted in a non-obstetric critical care unit like medical ICU, importance is given to mother, but baby is least important. As an obstetrician, as an anesthetist, OB anesthetist, as an intensivist, for me, both mother and baby are important. And when a mother is delivering a sick mother is delivering a child, the baby also is sick. And the co-ICU admission rate is very high, and we have to communicate. See that the mother is a regular update, the mother is in a state of about the baby's condition, because we don't want lactation failure. Lactation failure is very high. So even if the baby is sick, we at least do a video counseling or video bonding. Like in this case, a septic mother recovering from diabetic, it was a septic shock. The video of the baby is shown, and the bonding is established. So as an anesthetist, intensivist, OB intensivist, I want to minimize lactation failures also in this pregnant mothers. You can hear the baby crying. So basically, this was in a nutshell about the different causes of acute collapse that we see in our routine life. We can go into more details. So we will run the first scenario. Would you want to have a demo, or shall we straight away start the simulation? We have got time is a constraint.
Sorry, we have a small quiz, sir.
Okay, sorry. Okay. Small demo. Okay, then we'll run the quiz now. Yeah, we'll run the quiz. Thank you very much for the kind attention.
Thank you so much, sir, for that overview. I'm going to call the workshop and click on the link which has been sent for the quiz. Open the WhatsApp group of the workshop and please click on the link which has been sent.
Yeah, I have given. So if you have any problem. So good morning all. First of all, I thank new President Dr. Gauri Karandikar and her team for organizing such a wonderful workshop on the day of installation. So thank you for giving me opportunity to be a part of this workshop, and I welcome Dr. Sunil Pandya sir and Dr. Kausalya to Nashik and to OBGYN Society. It's my great honor to be with Sir and Kausalya. I have attended the workshop at Hyderabad and it was just wonderful. So I insisted Dr. Gauri to organize this workshop at Nashik.
We have privileged to have Dr. Hitler also today because he said he participated actively. So I welcome Hitler there in the audience.
So I think after delicious breakfast we are on toes to solve this quiz. This is actually a pre-test, but I wanted to make it interesting, so we are conducting it. So are you ready with Kahoot.it? And
Yeah, we are ready.
yeah, you all are ready? Yeah, I'm giving. So I think Dr. Gauri has arranged interesting gifts for first 3 winners. Is it?
Yeah, अभी तो देना पड़ेगा। पहले 2।
पहले 3.
नेगेटिव मार्किंग आएगा?
No, no.
Please, एक बार समझाने
So this is the game.
Please. Sure. Get them back. So game pin is.
So everyone is ready? Enter the game pin.
Announce करना।
6, 8, 6, 6, 7, 2, 6. So come on fast. Participants, I want 100% participation. It's really interesting.
जे पाहिजे ते नाव टाक.
So nice. I can see so many participants. Good. Come on fast. Even Pandya sir is participating, I think.
Everybody open.
Anybody not able to do?
Yeah, I am not able to.
What is the problem? Internet. Then you take hotspot from your friend. You need connectivity. Or as a team you can participate. 2 or 3 people can participate if there is a problem of connectivity. Should I start? Yes. Wait. So let us start.
Yes.
So we are starting with toes pre-test. So the following is not recommended in hypertensive crisis in pregnancy. So you have 20 seconds to 30 seconds to answer. Only 5 seconds. Come on fast. So the correct answer is nifedipine sublingual. In fact, we use nifedipine per oral. So this is the scoreboard. Sujata K. I think Sujata madam. She is the topper. So you should be very fast to get on the top. So next question, be ready. Which is a good sepsis marker? And here are your options. Come on fast. 71 answers. Okay, so the correct answer is lactate more than 4. I think sir had just told in his lecture.
Dawn?
Dawn, who is Dawn? So we go to next question. Dawn, be ready for next question. All of the following are true about PPH except just 5 seconds remaining. Come on fast. The correct answer is uterine atony almost always manifest as vaginal bleeding. So we go to see the scoreboard. Ashwini.
Who's Ashwini? Oh, wow.
Next question. This is the 4th question. The following is true about packed red blood cells transfusion, PCV transfusion. Come on fast. Correct answer is indicated if hemoglobin is less than 6 grams. Ashwini is topper. So next question. The ideal ratio of compression to breathing in maternal cardiac arrest is? Very simple, just now sir told. You have given so many answers. People have given correct answer. The correct answer is 30:2. Let's see the scoreboard. Again, Ashwini is topper. So next question. Antidote for magnesium sulfate toxicity is? You must know this as you are Again, Ashwini is topper. So we go to 7th question of our quiz. Non-shockable rhythm is. Come on, fast. You should discuss always these things with your anesthetist. Only 24. So, Nitin Patil.
Yes.
Okay, come on. Next question. Before initiating epidural labor analgesia, which investigation is to be checked? Very simple question. Six answers are already given. Come on, it's very simple question. So platelet count is the correct answer. We will see the score. Again, Nitin Patil. Where is Dawn? Dawn is not participating. During CPR for pregnant lady. Only 10 seconds. Correct answers. Scoreboard is again Nitin Patil is topper. So we go to next question. Indication of perimortem cesarean delivery. PMCD. Stopper again. Come on. We go to next question. So investigation of choice for P2L2 eclamptic patient with weakness in legs. So now last question of quiz. Before we go to last question, who is topper? Ashwini. And second Nitin and third is Shrutika. You have chance to win. So now we go to last question of quiz. Next. Fast answer. If you give fast answer, Ashwini, Nitin and Shrutika, you can be the first one, winner, topper. Come on. So here comes your 12th question. Algorithm for maternal collapse is. Correct answer is circulation, airway, breathing. So this is after collapse. Okay. So now we go to scoreboard. Let's see. Congratulations by Nitin Patil. Second is Shrutika. And here comes proper Ashwini. So I welcome all the winners to come. And I request Dr. Gauri to felicitate.
A big round of applause to Sunita for doing this download for them. Nitin, कहाँ है तू?
Congratulations Ashwini and Nitin Patil.
So thank you everyone for getting on your toes, and I ask Dr. Pandya to proceed now with the demo scenario so that we get an idea what we're going to do.
So, thank you, Sunil, that let us wonder. Few obstetric residents, 2 or 3 obstetric residents,
PG students,
PG students, and 2 or 3 anesthesiologists.
2 residents.
2.
No, there are 5 also anesthesiologists. My residents are here.
So resident and obstetrician part with anesthesiologist.
Okay. So basically, we run a scenario.
Lights on.
Patient's condition progresses, improves or deteriorates, we expect those 2 people to call for additional expert help. It could be a senior obstetrician, it could be a senior anesthesiologist, it could be a neonatologist, it could be a cardiologist, it could be a neurologist, and all equipment that is required is present here. All the specialists that are required are present around. So you just have to create a multidisciplinary team to go through the or navigate through the crisis. Okay. So this was the patient who was a 29-year-old, BMI of 28, comes with a leaky membrane and with a cold cervix. So the rescue circulage is done at 28 weeks of gestation age. She received shares of fetal maturity, and within 24 hours the pain becomes, she almost delivers. But because of fetal distress, she is taken for cesarean section, category 2 cesarean section. Okay, so can we run the vitals, please? Is it possible? 28. Leaky membranes, rescue circulation 24 hours back. Shivers were given 24 hours back. Now she is for category 2 cesarean section. These are the vitals. She is seated with theatre. Connected to monitor. These are the vitals.
Yeah, you are Dr. Prajakar. So now you have this patient. She is for spinal. Okay, you explain to the patient that you are giving spinal and you can give spinal. And then whatever happens on the screen, we will react accordingly. If you feel that you need help, you can call for help. And yourself?
Dr. Akshay.
Okay, you be the sister, okay, or you be the technician, anesthesia technician, and madam, your name? Dr. Shrutika Bhuya. Okay, you be the sister, okay, right? And somebody has to be the obstetrician. Can one of the obstetrician come? Your obstetrician? Okay, right, very good. Your good name? Right, sir. Yeah, you can wear the gloves. You first give spinal to her.
ताई तुम्हाला ना उठून बसायचं आहे, पाठीतून एक बारीक सुई लावून भूल देणार आहे, ठीक आहे? बसून बसा.
सो हे बघा, तुमचं आपल्याला सीझर करून बाळ बाहेर काढायचं आहे, तर आम्ही तुम्हाला आता उठून बसवणार आहे. आणि पाठीत एक अतिशय छोटीशी बारीकशी सुई देणार आहे. त्याच्याने तुमचा खालचा भाग फक्त बधीर होईल, तुम्ही जागे राहणार आहात. तुम्हाला कळेल पण अजिबात दुखणार नाही. कम्फर्टेबल राहा. ओके.
Now spinal has been given. Obstetrician come and deliver the baby. And you watch on the screen.
Okay? Yeah. You can deliver the baby.
So check the level and now deliver the baby.
Baby is there.
Deliver.
Yeah.
Oh, baby is delivered.
Doctor sir, I'm feeling little amount of pain. मुझे दुख रहा थोड़ा.
नहीं बट तो लेवल तो अच्छा था, क्यों दुख रहा है इसको?
मुझे दुख रहा है, सांस लेने में तकलीफ हो रहा.
ये O2 मास्क घ्या. तुम्हाला श्वास घ्यायला त्रास होतोय का?
मुझे
लांब श्वास घ्या. चला लांब श्वास घ्या.
डॉक्टर साहब, मुझे बहुत दुख रहा.
ऑक्सीजन मास्क लावा. ऑक्सीजन 10 लीटर पर मिनिट. कम ऑन. प्राजक्ता श्वास घ्या. बरं वाटेल तुम्हाला. लांब श्वास घ्या. श्वास घ्या. काय ते आय थिंक लेवल वर आली की काय. श्वास घ्या. लांब श्वास घ्या. बरं वाटेल 2 मिनिटं.
हाँ, ले रही हूँ. थोड़ा सा I'm feeling my heart is racing. Is it okay?
नो.
इसमें मुझे कुछ तो कीजिए ना. बेबी बॉय हुआ या गर्ल हुआ, मुझे देखना है.
बेबी बॉय हुआ है बट अभी आप आपके सांस पे ध्यान दीजिए.
मर जाती हूँ क्या?
नहीं आपको कुछ नहीं होगा. डोंट वरी.
I'm getting scared.
Saturation is dropping 70 and we are giving oxygen but still it is dropping. Call for help.
Mama, call an assistant.
I am the senior person, okay.
The senior anesthesiologist has arrived.
She collapsed, she is unconscious, unresponsive. No, she is unresponsive. So
not responsible.
she is not responding. Did you baby is delivered? No. Yeah. You intubate the patient.
Come on, first.
And can you secure another IV line, please?
Secure another ambulance.
Secure another IV line and start the IV fluids and check the BP. And yeah, you have secured the IV line. Take the samples. We'll send the samples. So whatever has happened, as it happened after giving the oxytocin, we will give oxytocin as bolus.
Have you given oxytocin as a bolus?
Huh?
Obstetrician.
Yes, I know. Anesthetic reading, no?
Yeah.
Okay. Okay. Since you are giving oxytocin as bolus, maybe this is because of oxytocin induced hypotension. And okay, we are giving the bolus. And what about the saturation? Maybe it is in the esophagus. Can you feel the carotids, please? Yes, fluids are running fast. Okay, we have sent the samples. You come. Sister, did you send the samples to the lab? Take an ABG. Let us put an arterial line. And carotids. The ECG is there. Can you feel the carotids? Okay. So let us start the vasopressors. Anesthesia technician. It's okay. Just put it. Sir, we have intubated. ETCO2 is coming. ETCO2 is coming. So it's only 20. Carotids are palpable. And let us check the saturation. Sir, we have intubated. ETCO2 is coming. Saturation. Noradrenaline is on. Noradrenaline is on. Fluids have been given. And is obstetrician, is she having any PPH? No, she is not having any PPH. It is retracted well. No PPH. Still she is having hypotension. Can it be because of anaphylaxis? We gave antibiotic after the baby delivery. Okay, so let us take some adrenaline. The pulse is not picking up.
Yes. And bolus. And what about the ABG? Okay. Pulse is 162. BP is not visible actually. BP is 80 by 38. So BP is improving. So let us keep another adrenaline ready. Let us give an hydrocortisone. And once the BP improves a little bit, let us give a Evil injection also. Hydrocortisone, yeah. She is improving. So this can be, most probably it may not be because of oxytocin bolus. So it can be either because of ceftriaxone, or maybe sepsis. So let us give another dose of antibiotic. And then, okay, since we have let us shift the patient to the ICU. And one of your obstetrician and the anesthetist, please go and counsel the patient's attenders that the patient will be in ICU for 1 day. And thank you so much. So,
big round of applause for the volunteers.
Sir, you can take this.
So, if you can, what do you feel was the diagnosis? High spinal. Oxytocin bolus. Anaphylaxis. Why not occult cardiac disease? Why not sepsis? Leaky membrane, PRM, retinal become received steroids. So the thing is, whenever the take home from this thing is, probably if you see initially they are lost, they are not reacting, the blood pressure from 110 it fell to almost 70, then they started SFSR. So good thing is at least they intubated the patient promptly, whatever reason. So whenever you have a crisis, when the patient has catastrophic fall in pressures or saturation, ABC should be the mantra. Airway, breathing, circulation, as has been said by Dr. Sunil Pandya. And if the patient has cardiac arrest, then CAB has to be the mantra, like chest compression, airway and breathing. So importantly, it could be anaphylactic shock, yes. She received cephaloxime as a dose, primary gravida not exposed, or it could be high spinal. How do you rapidly diagnose high spinal? In 5 seconds. So checking the health is not practical. Ask the patient to cough, ask the patient to talk, and ask the patient to hold the finger tightly. So finger grip, cough, talking, virtually rules out high spinal. So at least it is unlike this high spinal. Oxytocin possibility is there, but switch off oxytocin. And half-life is about 7 minutes, it should come out. But when the patient is persistently, like if you have stopped oxytocin, despite the decrease falling, there is no atomic PPH. You did ask whether the patient is bleeding, because that's when your persistent hypotension, no hemorrhage, think of others. Or sometimes there can be retroperitoneal hemorrhage or broad ligament hemorrhage which can go undetected. So you need to have an eye of a surgeon, yes, eagle's eye, but at the same time have a wide differential diagnosis. So A, B, C, D, E, UPS is what you have to go through the algorithm. And believe me, you can virtually rule out every damn thing with this algorithm. But if you don't understand anything, just treat symptomatically. If the BP is low, raise the blood pressure. Sats are low, improve the saturation by giving more oxygen. If the pulse rate is very high, then control the pulse rate. If the blood pressure is very high, control the blood pressure. So basically, and then as and when you are treating symptomatically, also think of differential diagnosis that you can give a targeted therapy, which is very important. Okay. So we'll conclude this scenario. We'll run the next scenario.
One word, sir.
Yeah.
Yeah, it's the same anaphylaxis occur. Usually we don't administer the antibiotics in the theatre. We administer the antibiotic half an hour before the surgery. So if the same anaphylaxis occurs in a patient, pregnant patient who has received an antibiotic, usually we give a test dose. But sometimes it may not occur with the test dose. Once we give the entire dose, immediately the patient can collapse, mother can collapse. If you suspect that it is because of antibiotic, if the patient doesn't have an IV line, immediately give IM. Don't to secure an IV line and give adrenaline IV. So immediately give IM. Okay? So adrenaline IM. if you really suspect it is because of your antibiotic or anything, if you suspect that there is anaphylaxis, immediately give IM and then secure an IV, and then third point is run the IV fluids and then give Evel. Okay, Evel and hydrocortisone come together. Okay, if you give Evel first, because that is the immediate reaction for all obstetricians that the patient should receive an Evel. So if you give Evel without securing an IV line and without giving IV fluids, that can also cause hypotension, aggravate the hypotension. Okay, and the rest of the things same as CPR. So you airway breathing circulation along with the wedge. So here the wedge comes. Wedge is very important. So just because you wanted a topic on anaphylaxis, sir has added this. And this has been along with the spinal. But suppose the patient is not in the theatre, then you have to keep a wedge. That is one thing very, very important. Okay.
Now that I think we finish up the discussion part also. Like we just briefly touched upon management of sepsis. Have you seen any septic shock in your practice, obstetric septic shock? Not yet, one hand. How did your patient come exhibit?
The patient came in shock actually, hypotension, and turned out to be septic.
So how do you notice the septic shock? See, in pregnancy we have 5 types of shocks, or rather 6 types of shock. Distributive shock, which is nothing but sepsis or anaphylaxis, cardiogenic shock, hemorrhagic shock, neurogenic shock, and there is one condition in pregnancy that has hemorrhagic, hypovolemic and neurogenic shock. Anybody? Inversion. Inversion of uterus. Yes, you have hypovolemia, you have profound hemorrhage, and importantly, because of retraction and uterus will be pulled out, you have neurogenic shock also.
That will be under the neurogenic.
Yeah, neurogenic shock, but it's a mix of different shocks. An obstructive shock, which is nothing but because of tension pneumothorax or pulmonary embolism. So whenever you have this patient with shock, there are certain always telltale signs. In the sense, this patient has persistent tachycardia, initial onset of breathlessness history is there, history of PND is there, then most likely it will be a cardiogenic shock. Sudden massive hypotension, there is no coagulopathy, could be embolic shock. Sudden massive hypotension, hypoxia, seizure, coagulopathy, amyloidic embolism. And sepsis. So when you think about septic shock, there are, as I said, 5 principles. Number 1, measure lactate, do an EVG. Number 2, send cultures. Number 3, send or start give empirical antibiotic. Generally, the antibiotic that we recommend is piperacillin-tazobactam with metronidazole. Or hit hard, hit fast. Meropenem, you can give loading dose of 1 gram as an infusion, not as a bolus, and along with metronidazole, because yes, meropenem per therapy can be, but hit hard, hit fast will be a mantra. But anyway, we have sent cultures. So lactate, cultures, antibiotics, and fluids. Again, what fluid to be given? Generally, we recommend crystalloid resuscitation. No colloids in sepsis, no hemaxil, no gelofuscin, no starch, only colloid that we recommend. If at all, the oncotic pressures are always albumin, 20% albumin or 5% albumin. Otherwise, no colloids. And then source control. Source control. If you feel there is a sepsis within the uterine cavity, terminate the pregnancy. Otherwise, yes, if you feel it's a non-obstetric cause, it could be acute pyelonephritis, it could be acute appendicitis, it could be acute cholecystitis, it could be pneumonitis. So head-to-toe examination is to be done, not to undermine a breast abscess, because we have seen breast abscess even in antenatal mothers, antepartum period. So examine, have a champion if you are a male anesthetist, male obstetrician, examine the breast and look for the source of sepsis, and source control is a paramount problem. So lactates, cultures, antibiotics, fluid resuscitation, vasopressors and inotors. A word about vasopressor. What is the vasopressor of choice? Alright. Now we have given fluid 30 ml per kg. Generally we recommend 20 to 30 ml per kg because again overloading a partial, like let us say a patient has preeclampsia. If I give 30 ml per kg, she may go into pulmonary edema. So at least start with a 10 ml bolus, give another 5 ml per kg bolus, give another 5 ml per kg of bolus. And nowadays you have ultrasound machines who are anesthesiologists also well versed putting ultrasound, so you can just check the contractility, check the IVC. Again, IVC diameter. Antepartum period is not very helpful, but postpartum period you can do a passive exercise, you can assess the volume assessment. Very important. So, lactates, cultures, antibiotic, volume or resuscitation 20 to 30 ml, stepwise manner, vasopressors of choice is noradrenaline, generally can go up to 0.1 to 0.2 ml per kg per minute. If the pressures are still not picking up, start vasopressin early. Vasopressin also can be started because it causes intense vasoconstriction, it helps in improving SPR. Especially in sepsis, it acts very well. So don't wait for the supranormal dose of vasopressin to be reached. Halfway through you can start vasopressin also. And importantly, source control. So, and despite that, the blood pressures are low, then you can empirically give hydrocortisone, because whenever you have profound overwhelming sepsis, they may develop adrenal insufficiency also. So, about 200 milligrams of hydrocortisone per day, 50 milligrams QID, you can give for 2 to 3 days till the pressures are to a respectable level. So, how do you know that the patient is improving? Drop in lactate levels. So, if the lactate is 5, it becomes 10, that means your resuscitation efforts are inadequate. If the lactate is 10, it drops to 5, that means your resuscitation goals are at least are successful and it's helping the patient to recover fast. So lactate, do blood test every 6 hours. How many of you have blood test machine? Access to blood gas? I think Nashik should have, I was told by Dr. Hitendra this morning, there are 5,000 beds in the perimeter of 2 kilometers from this portal, it seems. 5,000 beds, hospital beds, which is phenomenal. So at least for every 500 beds, there should be one EVG machine. Like blood bank, you need to have EVG machine, because EVG will not give you the diagnosis, but EVG will tell you this patient is critical or non-critical. If you see a normal EVG, you can go have a cup of coffee, take a nap of 1 hour and come back. But if the pH is low, as I said already, all the systems are super compensated. And there is no further reserve in the patient, and they decompensate very rapidly. So EVG is one thing which is very, very resourceful, very helpful. You need to have it early. So sepsis, lactates go hand in hand, cultures. So in bottom line, sepsis, hit hard, hit fast. As soon as you get the culture, you can de-escalate the antibiotics and measure with the time. Septic shock, the mothers, if you look at the mortality rate, is almost 60 to 70%. But if you hit hard, hit fast, you can bring down to less than 15%. Okay, so very, very important. So, if any doubts about sepsis, septic management, fluid resuscitation, only crystalloids. When I say crystalloid, balanced salt solution, preferably. I have no conflict of interest, but balanced salt solution are isoosmolar with plasma. Like ringalactate also is good, but let us say you have a septic shock with in a HELP syndrome or in a AFLP. Already hepatic functions are deranged. If you are giving ringalactate, the lactate is not metabolized to bicarbonate and the mother can go into lactic acidosis. Hence, balanced salt solution helps in these cases. Why not normal saline? Yes, normal saline is excellent crystalloid, but normal saline contains only sodium and chloride. It is osmolarity is isoosmolar with plasma, but it causes renal vasoconstriction. And importantly, overzealous crystalloid resuscitated with normal saline itself can cause metabolic acidosis, hyperchloremic metabolic acidosis. So again, it's not a preferred chloride. You can give up to 1.5 liters, not beyond that. Okay. So fluid resuscitation, choice of fluid is balanced salt solution. Again, you have several commercial preparations available, but poor man's solution is ringalactate. If you have nothing, there is no harm in giving ringalactate. Okay. So with that, we move to the next scenario. Very interesting scenario. This lady, I want again 5 volunteers. 1 anesthetist and 4 obstetricians.
Sir, I think you just called them.
You have already allocated the batch, no? Yellow batch. Make it 5 jane yellow batch se.
Yellow.
I will have Dr. Hitendra also for this case.
बस मैनेज करायचं ना आता.
So this lady is
I don't mind. Okay, I'll come for help. Let it, we'll come for help. Let her come for help. She's a helping obstetrician.
So basically what we want is initially one of you will become the nurse. Yeah, initially. Huh? Same as that, yes. Huh? Obstetrician. So, is there? Huh? We don't know, it will be a lady scenario. Yeah. So basically she is a grand multi G5, P4, L4, previous 3 normal deliveries section, and now she is for cesarean section with tubal ligation. Okay, and she is for category 4 cesarean section, elective cesarean section, and waiting for regional anesthesia. There is a small change in scenario. She is for normal delivery. Grand multi, previous for normal delivery, the 5th normal delivery. Okay. This typical noisy labor room. So role allocation is very important. So how many of you have had opportunity to do simulation workshop earlier? Or how many of you have attended CPR workshop, ACLS workshop? Many. So when you do this ACLS or CPR workshop, one of the things that is very important is leadership. One person has to be a leader. Okay? So what we expect in the team is one person, when the crisis develops, takes a lead role and orders. And it has to be a closed loop communication. If I say, give oxytocin, that is oxytocin how many units? Let's say 5 units. IM or IV. You have to be very clear. Okay, give oxytocin 5 units intramuscularly or 10 units intramuscularly. And then given. Once the drug is administered, given. That means the loop is closed. Okay, so closed loop communication, all these things, and there has to be one leader. So this patient is for normal delivery. Okay. She is come with labor. She's 7 centimeters, almost 10 centimeters, 8 centimeters dilated.
Yeah, patient is 8 centimeters dilated. She is a third gravida, as already told, and this is okay. So, madam, she is progressing fast. She is fully dilated now. Yeah.
So now you just push it.
Madam. Madam. I am pushing. Yeah. Yeah, you can pull out the baby. The baby is delivering. She is a third gravida. Yeah. Now the patient is having a baby delivered and oxytocin IM. Yeah, the oxygen wanted 10 units intramuscular. Yeah, it was given. And now the patient is having little amount of PPH. Okay. So
Placenta is coming.
yes, madam, placenta is come. Placenta is delivered now. Patient is having PPH.
Now bimanual massage.
Okay, they are giving bimanual massage.
Injection prostuding intramuscular 1 ampule.
Injection prostuding intramuscular given.
Keep vitals monitoring properly.
Vitals are as of now stable. Little pulse rate rise is there.
Put another white bore intracat.
White bore cannula secured.
Send blood for the grouping cross matching 2 bottles.
Blood for grouping cross matching sent. Fetal drip started.
Ask for another obstetrician if at all primary obstetrician needs.
Another obstetrician is on the way.
So the patient is still in the patient is in the labor room still, and
Blood loss kitna hua? Just how many mops are there?
So
Yes, placenta completely out. Okay, but how is the uterus?
so the blood loss is the patient is having PPH. The blood loss is around 1500.
500.
The uterus is not contracting, madam. Uterus is still atonic.
IV is going on, blood is on the way, and already asked for a blood.
Okay. Can you see the monitor? The BP is 79
The
by
BP is
38.
79. I'll push the IV fluids.
Okay.
Yeah. I'm pushing the balanced salt solution.
Okay. The anesthetist has come to the labor room. Yeah.
If the uterus is contracting, explore her for the cervical tear and other things.
So you want the patient to be shifted to the OT?
Yeah.
Very good. So, okay, you are shifting the patient to the OT.
O2, I'll put a start O2. ठीक लगेगा, आराम से सांस लेते रहो,
मुझे 2 बच्चे हैं सर जी, मुझे तो कुछ नहीं होगा ना?
नहीं कुछ नहीं होगा आपको, आप
3 बच्चे हैं।
आप सांस लेते रहो, आप चिंता मत करो, आप सिर्फ सांस लो। Keep the Nora ready. How is the bleeding?
ये क्या लगा है? मुझे अच्छा नहीं लग रहा सर जी, निकाल दो ना प्लीज।
ठीक लगेगा, आप इसमें से जरूरत है, आप सांस लेते रहो।
सांस प्लीज कुछ नहीं लेना है, मुझे वो निकाल दो ना प्लीज।
आप सांस लेते रहो।
सांस तो मुझे भी लेने का है। I'm not feeling comfortable sir, कुछ तो करो ना।
Same blood for the
blood is
same blood for the arterial gland cancer.
Now the BP is 66 by 29. मुझे वॉमिटिंग आ रहा है। 66 by 29. So you have shifted the patient to the OT. Yeah.
This is the BP.
6629.
I start.
Patient is in OT.
Blood push करो.
Blood has started and uterus is contracted properly, but there is a cervical tear and we are going to suture it immediately.
सांस लेते रहो, इसमें से सांस लेते रहो.
You want to integrate or
Yes.
66 by 29, sir.
I started I'm pushing the blood and I started the supports also. I'll check patient is still breathing well. Saturation is maintained. सांस लेते रहो.
So, how much time has passed, sir? And what is the
Take the
4 hours? 4 hours.
Patient is consciousness is reducing and
Patient is
saturation is falling. I'll go for intubation. Intubate the patient.
Yeah. Now already it's 2 hours since the patient is delivered, and the patient, the obstetricians, they have decided to go for a laparotomy and also cervical exploration. So they have did a cervical exploration. Cervix is there are no traumatic features on cervix.
Patient
So ultimately
intubated.
it is an atonic PPH. So they have started for the laparotomy. Okay. Do you want any blood and blood products by this time? Yes. So any blood products?
2 fresh frozen plasma and PCV.
Okay. How many packed cells and how many?
4 packs of volumes and 2 FFPs.
Sir, you want to send any ABG for this
Yeah,
patient?
already sent one ABG sample. Patient is intubated. Ventilation is going on.
pH is 7.1, pH is 7.1, INR is 4, APGT is 70 seconds, Fibrometer is 90.
I'd like to push
Now
the
the
FFP
INR
to
is
this
4.
patient.
Yes, sir.
Tranexamic acid given. FFP, I am pushing the FFP to the patient. How's the bleeding?
The patient is still bleeding, uterus is still atonic, and they are proceeding for hysterectomy.
Madam,
Okay.
still the INR is 4, so it sees in a consumptive coagulopathy.
You
Yes.
are ordered only 2 FFP. Do you want to?
Immediately a package of 4.
Yes, sir. So they are
Rhythm
ordered
is
for
changing.
4.
Get the crash card. Call for a hall.
Sir,
Get the crash card.
you want to go for any extra lines?
Yeah, I had already secured a whiteboard line. And fluid is going on fast.
Okay, sir.
We are repeating tranexamic acid, 1 gram already
We
given.
are proceeding for abdominal hysterectomy. BP is not changing. Saturation. So patient is on.
We are pushing the fluid and we have started the vasopressors as well.
And we will remove that because it is atomic PPH and it is not contracted. So just to go for that.
So they have already started resuscitating the patient with blood and blood products, and they have given fluids also. And since the patient is not responding, since the patient has gone into atonic PPH, they are going for cesarean hysterectomy, and cesarean hysterectomy is done. The BP is improving, but then the saturation is falling. Temperature is also falling, 34.1.
So I think patient is to be shifted to the tertiary center, reference center.
They need to stabilize.
This scenario in our hospital.
Now, patient is not in a shiftable condition.
I thought this is a primary center.
So whatever center we have, we cannot shift the patient. We need to stabilize here. Yes.
So I call for the another best.
We have started the warm fluids. We have started the warmer also.
Yes, sir. So they have started the warm fluids and warmers. Blood and blood products, sir.
Yeah.
Because INR is 4.
Now the rhythm has changed. Get the crash card, please. Get the. We need to give the shock. Prepare the saturation. Prepare the shock, please. Okay. Chest compression. Start chest compression. Do shock.
I have given the DP.
Yeah. Shock given.
Shock given.
Continue chest compression. Continue
And the
chest compression.
saturation is not coming.
30 is to 2 and giving CPR.
30. Breathing is going on with the speed of 10 and continue the chest compression.
Yeah. Since they have
Adrenaline. Keep the adrenaline ready. 30 is to win.
No, we have already
Keep the
intubated. No,
adrenaline.
it is 100
Yeah.
per minute. It is no longer 30 is
30
per
is
minute.
to win.
It is 100 per minute.
Keep chest compression. Keep
Now,
going. Ventilation
saturation
is
is
100% is going on.
Yeah, saturation has picked up and even the rhythm is
Continue the
changing a
chest
bit.
compression till the BP comes up. Continue the chest compression. ETCO2 is still low.
Can you check the therapies?
Yeah, continue with the speed of 120 per minute. Count. Change the role. Rhythm is picking up. Rhythm is still.
You have to complete 30 is to 2, 5 cycles and then change the role. So if 2 resting CPR is going on, it is 30 is to 2.
Can check the therapies? If the carotids are there, you can stop the CPR.
Yeah, carotid, I can feel the carotid. Terminate CPR, stop chest compression, continue ventilation.
Now hysterectomy is done, patient is arrested and the patient has revived and she is no longer bleeding now and BP is also picking up. We have resuscitated the patient with blood products.
One more ABG and complete CDC.
Close monitoring for next 2 or 4 hours because 24 hours, but first 4 hours are quite crucial because she may again go in hypotension, so you have to take care and you have to arrange for blood components and do CPC because you should know about coagulation profile because you have given so many fluids, crystalloids are also given, platelets and plasma also given, so you have to do close watching of patient and monitoring of patient.
Congratulations team for excellent management of PPH.
We do the D-dimer test every 20 seconds.
Thank you, madam, and thanks all of you. Thank you, sir.
Giving round of applause to the team members. We have prevented the maternal death.
Sir, will you replay this? You want to replay this now or you want to just
Yeah, better to replay. Just replay करो. Replay करो. Replay करो. So we don't want those things to happen. Okay. So post-operative monitoring is very, very essential. And once the coagulopathy is under control, do not forget to start low molecular heparin because DVTs are very common, especially if you are over-aggressive in combination therapy. INR can drop to less than 1, and you are reducing a pro-thrombotic state. So once the coagulopathy is under control, start anti-DVT prophylaxis. Any mechanical prophylaxis has to continue right from pre-op, intra-op, and post-op, but LMFs also can be initiated. And one more thing, overzealous crystal resuscitation can cause abdominal compartment syndrome. This groove tense at level. You may think it is blood loss, you may think it is bleeding, but it can be mental edema and bowel edema. So restrict permissive hypotension. Concept of permissive hypotension. No overzealous crystal resuscitation. And fast transfusion early and completely. So I just try to conclude with in one line: too little of blood, too much of blood, too late of blood transfusion are all eternal perils. Minimize it, avoid it. Okay? With that, I think it's a problem with the
as obstetricians, if you are in the labor room, what you have to do is, if the patient is having PPH, ask someone to note the time because we will be so involved in giving suppose we are suturing an episiotomy or we are giving a bimanual compression, we won't see the time and it becomes 1 hour within 1 minute. Only we can understand that. So when the patient goes into PPH, immediately ask someone to note the time, notify the anesthetist, put oxygen to the patient, secure another line, and then if at all it is possible for you, secure an EJV. So securing an EJV is easy, and we usually secure an EJV on the left side so that we can put an EJV is external jugular vein. So that we can put an IJV after some time. This is not an emergency. But if you have a line, sometimes we won't get the lines in the hands. But EJV is visible and we can easily do it, or your anesthetist can do it. And the second point is how much crystalloids, as sir has said. 4 crystalloids you can give to a patient within half an hour to 1 hour if the hemoglobin is more than 10. No issues at all. If the patient is still having PPH after you giving 4 RLs, then you have to get the blood. So how much blood and when to get the FFPs? 2 bloods immediately, and if the patient is still bleeding, ask for another 2 more bloods and 4 FFPs. If you don't have any APTT-PT INR in your setup and if it takes time for the APTT-PT INR reports to come, okay, yes, if you have ABG, you can send for the ABG. Another important point which I noticed where we, this one is we don't realize is if the patient is having health syndrome or a patient who is having eclampsia and the patient is on MAXF. So when the patient is on MAXF and the patient starts bleeding and you give massive transfusion and the anesthetist gives the calcium to the patient and in the post-op patient throws a fit. because they have given calcium and already the magnesium is lost. And so what in our hospital, what is the protocol is, if the patient is on Maxel and if the patient has massive obstetric hemorrhage, then either continue the Maxel as an IV infusion of 1 gram per hour or give a loading dose of 2 grams. If the patient has a hysterectomy, no issues. But if the patient is having an intact uterus, that uterus can have atonicity because of your Maxel, and again she can bleed. So you should take all these points into consideration, but always make it a point to give 2 grams of magnesium again as a loading dose. So shall we move on to the next scenario, sir?
This is the patient who is admitted.
Good morning, Dr. Krishna. I can present tomorrow. So, good morning. How are you? What are you having? Do you have some headache? You have some pain?
No, I am good. I am absolutely fine.
Are you passing urine properly? How many times did you pass urine?
Well, madam, I got little hoarseness.
Do you have any difficulty in your breathing?
No, nothing as of now. But they told me in the emergency room, the obstetrician who examined me told me that I have got high blood pressure. Is it going to be a problem for me, madam?
No, you are here safe and
Am I safe?
take care.
Will my baby be
Did you
alright?
sleep well yesterday night?
No, it was very disturbed sleep because I was worried.
Okay.
Will my baby be alright, madam?
Yeah, sure. Do you have a feeling to vomit?
Now, 4 hours of lapse. 4 hours of lapse.
Can you see properly how many fingers have been?
No, I'm having a little blurring of vision. I'm having a little headache also.
Okay. Sister, please take blood pressure.
I'm having severe headache and blurring of vision, madam.
Okay.
Will I be
Sister,
alright, madam?
sister, please, how much is the blood pressure, sister?
You can see the monitor.
Sister, please, please give me return 20 milligrams. Yeah, please take this tablet. Sister, please give me catheter. Police catheter.
I'm having a little tightness in the chest.
Yeah, police catheter. Yeah.
I'm having a little tightness in the chest.
Okay. Please bring the report.
I'm having cough, madam.
Sister, please call the union.
डॉक्टर सांस लेने में तकलीफ हो रही है, दिक्कत हो रही है, छाती में एकदम टाइटनेस हो रहा है, कुछ होएगा तो नहीं होगा?
Please call
Hello, what's your name?
I'm Padmaja. Yes. I'm breathing, सांस लेने में तकलीफ हो रही है और सर में दुख रहा है, धुंधला बना रहा है, आपके सामने नजर कमजोर हो रही है।
हाँ, शांत रहो। I'm here to help you all. Okay, sister, prop up करो। थोड़ा सा prop up करो, O2 लगाओ।
प्रोडक्ट कर दी सर, O2 भी लगाए।
अभी बीपी कितना रहा? क्या क्या दिया है?
जिसम में गरम हो रहा है, कुछ दवाई से होता है क्या?
What's your plan of action?
Now, we need to reduce the blood pressure, so
Sir, she is throwing the fit.
Okay. Okay, I'll ask my seniors to come over.
Hold the mask. Give midazolam. Hold the mask. Secure airway. Secure airway. Incubate. Give midazolam. Midazolam given. Keep propofol ready. Patient intubated.
Sir, midazolam given. Propofol is also ready.
Propofol. Give propofol.
Propofol
10
ready,
cc.
sir.
Give 10 cc propofol.
10 cc propofol. I am giving 10 cc daily, sir.
Keep ventilating. Keep a watch on the BP.
Sir, 10 cc propofol given and bag mask ventilation is being done. Sir, saturation is still falling.
Keep ventilating with 100% oxygen. Keep a watch on the BP.
Yes, sir. BP is now.
Secure fluid line. Secure one more IV line.
Sir, IV line secured.
Start fluid. Balance salt solution or RL.
So RL started, sir. Full flow लगा है.
Patient count is 88,000. LDH is 540. SGT, SGPT is 90, then 110. Hemoglobin is 12.8 grams.
Hydrocortisone. So hydrocortisone given.
How much is the urine output? Is she throwing urine?
20 ml. Clear.
Okay. So what are your plans, ma'am?
Induce the liver. In this case, you have to see the CTG findings and as well as the PV findings.
The pathological CTG, madam.
It's pathological, then immediately take her for cesarean section only. Deliver the baby, and after delivery, she might the convergence might reduce, and then start with the Maxel, either 4 hourly or 8 hourly, depending upon the convergence rate.
Platelet count is 62,000 now. Post-operative, repeat platelet count.
Surgery done, sir.
Surgery is done, yeah. So 60,000, then again she has to arrange for the blood. She has arranged blood, no? Yeah.
Sir, surgery is done. Patient is extubated, shifted to the post-op.
There is no active bleeding. There is no active bleeding. There is no active bleeding. Surgery is done. Still not extubated.
Patient is not extubated. Patient is shifted to the ICU for elective ventilation. And like to do the ABG and correct the hemodynamics as well as acidotic changes. And keep her under cover of anticonvulsant.
Patient is having oligogamma and pupil is dilated. One side pupil is dilated.
You can give, will be giving acids or cruciferide.
Pupil one side is dilated.
So there might be cerebral edema, so in the view of that, I can give the cruciferide or Datol. So mannitol can be given.
Keep ventilation with saturation is falling. Saturation is falling, so keep ventilating with 100%.
I think anyway, round of applause and she was being given bed rest therapy. And 4 hours after admission, she started having learning of vision headache, and 220, 140 was the blood pressure, and that's when the operation was fought. So when you have a patient who is admitted with preeclampsia and without severe features in the ward, what is the thing that you ask the nurse in specific monitoring to be done in the ward? Warning signs. Modified obstetric early warning chart. I hope everybody is following this. That should be mandatory. So what we expect, the obstetrician who comes at that time, can I review the chart? last 3 hours, how was the vitals. Okay, now this patient is having preeclampsia with severe features. Okay, so what is the goal now? She is still there in the ward. Shift to the labor. So that should have been very clearly inserted. Sister, tell the patient to shift to labor room or intensive care unit, HDU, high difficulty unit. So I don't want to give Labetalol or IV Labetalol in the ward. No. So shift the patient to the HDU or ICU or labor room where you are intensely monitoring. That is one thing. Second thing is, I heard nicotine 20 milligrams free. So how do you manage accelerated hypertension? This is a case of accelerated hypertension. So accelerated hypertension can be hypertensive emergency, hypertensive urgency. Emergency is when you have end organ damage. Urgency is there is a potential for end organ damage. Okay. So anyway, at this moment of time, there is no end organ damage, it's urgency. So how do you manage hypertensive urgency? Injectable oral. Oral, if you want to give oral, the drug of choice is oral plain nifedipine, no sublingual nifedipine. Because sublingual nifedipine can cause overshoot hypotension. We don't want that to happen. Or sometimes it cannot act because anxiety, the mouth is dry, absorption is poor, and suddenly the absorption can happen after some time. So erratic action. So give orally. The only thing is it takes about 45 minutes to 1 hour for the action to begin. So IV injection, Labetalol is the drug of choice. 20 milligrams IV over 5 minutes. Wait for 10 minutes, 5 to 10 minutes. If it's still high, give another, give 40 milligrams. Give double the dose after 16 minutes. So you can keep on escalating the dose of Labetalol up to 220 milligrams, 24 hours. But control of blood pressure, the blood pressure at a given point of time should not fall by more than 30%. So the targets of blood pressure management in active hypertension, you all know, you are the masters of it. But I don't want systolic BP to be less than 140 and diastolic BP should not be less than 90. Because you don't want 110 by 70 blood pressure, 90 part and severe preeclamptic. Okay? So that is very important. So because of persistent hypertensive crisis, the patient went on having systolic blood pressure was high, diastolic blood pressure was high, so we need to decompensation, pulmonary edema. Acute pulmonary edema. So pulmonary edema, if you look at the commonest cause of maternal mortality in hypertensive parturients, anybody? What is the commonest cause of maternal mortality in parturients who has preeclampsia? Intracranial bleeds. Second is pulmonary edema. Very common. So we don't want mother to die because of pulmonary edema, but as the expert will call rightly, first and foremost is header. Header preposition. Propped up position. High flow oxygen mask, we were discussing about this in the afternoon. High flow oxygen mask is very, very essential. Just give 15 liters of oxygen or BiPAP or CPAP, we will discuss more in the afternoon workshop. But importantly, ABCs, pulmonary edema ABCs are very important. And furosemide. Only indication of giving furosemide in the antepartum period is pulmonary edema. Because we don't want maternal hypoxemia to worsen. Because as I said, the lethal triad of fetal demise is hypotension, hypoxia and anemia, hemorrhage. H. Hemorrhage, antepartum hemorrhage, hypoxemia, persistent and persistent hypotension. We don't want that to happen and cause fetal jeopardy. Because we want to give best to both the lives. So, Maxwell therapy was initiated, but before initiating Maxwell therapy, would you like to check anything? Reflexes. So, basically, it is very essential that you check the baseline reflexes. Many a times, I would say, 10% of women, they have baseline hyporeflexia, even in preeclampsia with severe weakness. So if you have not checked reflexes and you have given loading dose of Maxel and subsequently you monitor reflexes and this is hyperreflecting, you are doubtful. Or is it because of Maxel toxicity or is it because of baseline? We don't know. So always it is prudent on the part of clinician to check baseline deep tendon reflexes. Very, very essential. And many a times we see the jerk. Many a times jerk is an action, but you have to see the contraction of the fasciitis muscles. Very, very essential. So you need to see that the thigh is exposed and you look at the reflexes. And this is extreme reaction. But check of reflex is very important. Whether you want to give IV Maxel, IM Maxel, up to you, but when the platelet count is less than 80,000, better to go for IV regime. It is safer and more effective. The Pritchard regime, intramuscular regime, is more painful and little erratic absorption. But if you don't have adequate monitoring, then whatever regime you want to follow, you follow. But see that you give Maxel. Maxel is the drug of choice in eclampsia or prophylaxis. Seizure, in this case, it was started as a prophylaxis. Despite prophylaxis, patient has thrown a fit. So what do you want to give now?
Give Maxel only.
Give Maxel. So this is exactly what I want to impress upon. But the only indication of midazolam and propofol is status eclampticus or status epilepticus. So do not give polypharmacy in antepartum period, because if you are giving Maxel, if you are giving propofol, those are the indications of putting a tube. So we don't want to see eclampsia does not require intubation. Pulmonary edema does not require intubation. Just because what happens is the moment we come into picture, we see hypertension, we want to secure airway, which is good in a way, safe. But not all patients they require intubation, because once you intubate the patient, then what? Oxygen wants to wait, CTG is fine. So most of the time pulmonary edema is self-limiting, it gets cleared up. Eclampsia is, yes, once you have eclampsia, you have to terminate the pregnancy, but stabilize the mother, very important. And post generalized tonic and clonic seizure, if you run the CTG will be non-reassuring only. So left lateral position, reassure, within 20-30 minutes the CTG results in return back to normal. If it persists, then yes, you need to terminate. But see that stabilization of mother is very important. And so management of hypertensive crisis, laboratory is the drug of choice. Now I will give you a scenario where you have a parturient who has underlying heart disease, underlying cardiomyopathy with preeclampsia, hypertensive crisis. Then what drug you want to give? Labetalol is contraindicated. Labetalol has negative inotropic, negative chronotropic action. And in the presence of cardiomyopathy, low ejection fraction, labetalol can cause heart attack and worsen heart. So what drug you want to give in this scenario? NTG is an evergreen drug, but when you are giving NTG, you need to have an arterial line, you need to have an anesthetist because it can cause profound hypotension. We don't want that to happen. I don't want hypotension to be less than 140 systolic, less than 90. So NTG can cause profound hypotension, yes. So NTG is a reserve. Hydralazine. Hydralazine is a wonderful drug. It is a vascular, it's a venodilator, and the dose is 5 to 10 milligrams slow IV boluses. So the beauty of hydralazine is it does not have any myocardial depressant action.
It's not India.
It is available in India. Bharat Serum has manufactured, it is available easily. So hydralazine, we have oral preparation, we have IV preparation. So by and large, labetalol suffices most of the time, but if the patient has underlying heart disease, then go for hydralazine. Okay, that is the point I wanted to convey. And pulmonary edema, the patient has pulmonary edema. In this patient, it looks like hypertensive crisis related decompensation, but patient can be having underlying cardiomyopathy also, hypertensive cardiomyopathy. You just have to keep that in mind and appropriately work up the patient. So the protocol of management of pulmonary edema, at least in our hospital, is all patients with pulmonary edema will need ECG, chest X-ray, or lung ultrasound, echocardiography, and EPG, so that any underlying often heart diseases can be picked up, or it could be simply simple straightforward pulmonary edema and permanent transient LV dysfunction will improve. Okay. The management of eclampsia, drug of choice is magnesium sulfate. While on Maxel, if the patient has one more seizure, the drug of choice again is magnesium sulfate. You can probably step up the dose to 2 grams and you can give again 2 grams loading dose again and probably make the infusion as 10 grams, 2 grams per hour. But there are certain conditions where you need to take rescue from alternate anti-epileptic medications. What are the conditions?
Intracranial bleed.
Intracranial bleed. If the patient, how many of you have had partial with myasthenia gravis? So myasthenia, magnesium sulfate is dangerous. So in that case, you need to go for alternate anti-epileptic medications, and you can have levetiracetam is maximally studied. You can give phenytoin sodium oxide maximally studied. But only thing is phenytoin sodium can cause conversion defects. You need to keep that in mind. But only indication for alternate medications to magnesium sulfate is myasthenia gravis or where magnesium sulfate is relatively contraindicated or absolute contraindication, like urea, loss of reflexes, hyperreflexia, patient is still irritable, blurring of vision is still there, then you need to give alternate medication. And benzodiazepine also can be given now.
Sir, 3 contraindications for Maxim, sir. As you said, myasthenia gravis. Second is acute pulmonary edema.
Yeah.
And third one is acute kidney injury.
That's what I told you, kidney. I said already you said acute kidney injury. So acute kidney injury also, you can always give a loading dose. AKI also you can always give a loading dose. The maintenance dose, you need to be careful. And routinely, do we monitor magnesium levels, serum magnesium levels? Not necessarily. Just reflexes, level of consciousness, respiratory rate, urinary output. If you are maintaining these 4 parameters, they are wonderful. We monitor magnesium sulfate only if any of these parameters are abnormal and you want to continue maximum because patient is still irritable. Okay. So eclampsia we have discussed, and what about this patient suddenly BP fell to 110/70? Is it something else or is it just because of propofol betazolam? Conversing patient. Abruption. Abruption, common thing in hypertensive crisis. So just have to keep your alertness, A, B, C, D, E, UPS. Am I missing something? Just go for that. So suppose this patient saturation fell for a long time. What could be the reason? What else could be the reason? It was not picking up. The oxygen still 92%. I intensely kept that. The patient was having low saturation. What do you think? Pulmonary embolism, why not? We don't know because patient has been on bed rest for long. Probably we don't know. She was. We have not taken adequate history that she was on bed rest 1 week before that patient. We don't know. So always keep in mind persistent hypoxemia. Is it pulmonary edema is resolved? Respiratory rate has normalized. Patient was on ventilator support. But see that you need to keep that in mind. And sudden fall in blood pressure is not picking up. Is it obstructive shock? You have hypotension and you have hypoxemia. So you just have to keep, if the thing does not improve, have a wide differential diagnosis. Keep your differential diagnosis alive. Just because the patient had excessive hypertension, cough, breathlessness, acute pulmonary edema, it could be something else. It could be cardiomyopathy, it could be pulmonary embolism. So keep an appropriate workup is very essential. Okay. So with that, we just conclude this scenario also. You want to add anything, anybody, from your experience?
So how much Maxel can be given? Maximum?
See, magnesium sulfate is a wonderful drug, category B drug. But it can become category D drug when you are very apt question. It can become category D drug if it is given beyond 72 hours antipartum. Okay, because it can cause osteoporosis in the fetus. So magnesium sulfate, all of it can be given 24 to 48 hours. By then the delivery has to happen. We can't wait, we can't sit for
maximum dose 4 grams, 6 grams we can.
Yeah, you have doing that. So you can go up to 4 grams loading dose, 6 grams loading dose, 1 to 2 grams per hour infusion. 2 grams per hour you can give as an infusion. And as long as it's an excellent margin of safety, as long as these 4 parameters are maintained, output of more than 0.10 per kg per hour, level of consciousness adequately alert, and adequate urine output, and importantly, rate. There is no bradypnea.
Sir, can you repeat why after 72 hours it is turning to category D?
Generally, by then the baby is out. No? The baby is out. By then the baby is. So generally, you don't give beyond 48 hours. So myself is otherwise a safe drug, but you need to keep these things in mind.
Intercurrent eclampsia. If patient is having convulsion, we want to continue the pregnancy. For 34 weeks.
So when you have when you have convulsion, which is atypical. In fact, Dr. Kaustubh in 2007 we produced a paper of peripartum seizures, and eclampsia is one of the causes, but there are certain other causes. So this patient, I said anisocoria. Importantly, mannitol. There is no role of mannitol. There is in cerebral edema. There is no role of mannitol. Mannitol will induce and worsen pulmonary edema. In this case, already stats are not improving. So mannitol, hypertensive, crisis, pulmonary edema, no. I mean cerebral edema, there is no role. Just maintain. If your patient is having a tube, maintain ventilation, but there is no role of mannitol. There is no. The only role of furosemide is acute pulmonary edema. No role of furosemide for cerebral edema. And importantly, Press syndrome. Press syndrome. What is Press syndrome? No, what is it? What is it due to? Basically, it is the breach of blood-brain barrier. So when there is breach of blood-brain barrier, whenever the systolic blood pressure rises, the blood enters the neuronal cells. So the breach is the auto-regulation is lost. So the management of Press syndrome is tight control of blood pressure. Maintain systolic blood pressure less than 150. Diastolic of less than 100. It's very, very essential because initially in Press syndrome you see vasogenic edema, and if you look at the MRI T2 flare imaging, attenuated image on the MRI, you see whitish whitish striae on the occipital or bitemporal or bifrontal areas, which are nothing but accumulation of fluid, cerebral edema. So basically you see this in, it's a basic preeclampsia with blurring of vision is clinical Press syndrome. It's only that MRI has made this as a diagnosis, but otherwise all patients who have imminent preeclampsia feature with blurring of vision, MRI, if you get MRI done, then you have a features of Press syndrome. So the management of Press syndrome is only control of blood pressure. It is seen basically because of low oncotic pressure. The ability of fluids to be retained in intravascular compartment is governed by albumin. And pregnancy is a low albumin state, hypoalbuminemic state. So the capacity of fluid to be held by albumin in the intravascular compartment is low, hence the fluid can go into extravascular compartment, interstitial compartment very easily. That is what is capillary leak syndrome. And hence they have a tendency for pulmonary edema, they have a tendency for Press syndrome. And if you ask me, Press syndrome occurs, other conditions where you have Press syndrome can occur is chronic liver failure.
Excuse me, sir.
Yeah.
We'll start with the next case
Yeah.
scenario as we have to finish all case scenario by 12 p.m.
Yeah.
Okay. So, members from Black Group are requested to come forward for the next case scenario. Dr. Gauri Pimpalikar, Sanklecha sir, Dr. Kalyani Sonone, Dr. Nikhil Sonone, Minal Randive and Dr. Samir Pawar. So we have to start our installation by 12:30.
Yeah, I got it.
Right? 34 weeks, she comes to triage area with severe shortness of breath. Right? Nurse attends the patient and we will carry on through the case. Okay? She is a 37-year-old pregnant patient. She comes to the triage area with shortness of breath. So, come. 37-year-old. Yeah, you can take the next.
So you will be the patient, you will give the voice over.
नमस्ते दीदी, क्या तकलीफ हो रही है आपको?
नमस्ते मैडम, मुझे सब कुछ अच्छा है पर लखनऊ थोड़ा सा ब्रेथलेसनेस हो रहा।
आपको सांस लेने में तकलीफ हो रही है क्या?
हाँ मैडम।
कब से है आपको सांस लेने में तकलीफ?
नमस्ते हो रहा, अब भी थोड़ा हो रहा।
आपको सर्दी खांसी बुखार नहीं है ना?
सब तो नहीं है, मुझे बहुत डर लग रहा क्योंकि मुझे
बच्चे की हालचाल ठीक है, मैं मैडम को बुलाती हूँ। हेलो, क्या हो रहा है आपको? डरो नहीं, सबसे पहले एकदम शांत रहो। हम लोग आपको ऑक्सीजन लगाएंगे तो आपको सांस लेने में आसानी हो जाएगी। ठीक है? बिल्कुल डरो नहीं, आराम से सांस लो, इसमें से सांस लो। अब थोड़ा ठीक लग रहा है? ठीक है, 1-2 मिनट रुक जाइए आप। मैडम, उसका सैचुरेशन कम हो रहा है। Keep a wedge and call for help. Wedge रखेंगे, call for help.
Now the saturation is
Call anesthetist, call senior gynecologist. संकलेता सरांना फोन लावा. This is routine scenario in psychiatry also. मैडम, वो आवाज नहीं दे रही पेशेंट. Wedge. Anesthetist. मैडम. Yes. Yeah. With the wedge. Sorry. मैम, उसको सलाइन लगाना है क्या?
the patient has become breathless and now the patient is not responding. So they have put a IV line and they have put a wedge also. And now they are asking, they are seeing whether the patient is responding or not. So what happens if the patient responding?
मैम, पेशेंट आवाज नहीं दे रहे.
So patient has become non-responsive.
भाई, डोळे उघडा.
So non-responsive.
Check for the pulse. Check for the pulse. Carotid is not felt.
Yeah, the patient is non-responsive now and there is no weakness, the saturation is not being recorded and also the ECG is showing a VT. Okay, so the patient is in cardiac arrest, right? So now they are proceeding now.
So I am confirming no carotid pulse, no respiration, there is no chest rise, there is no response. So call for help. I will call for one more anesthetist and help and I will start CPR. So I will start with compressions. While giving compressions, you come on. Other you come on. Start CPR. It should be in the center, just 2 fingers. You are giving a wrong position.
Yeah, so now you paused it, no? So yeah, so the patient is in cardiac arrest. This is a rhythm VT, right? So you want to give shock?
Yes. So as patient is in ventricular tachycardia, pulseless, then I will arrange for defibrillation. Get the defib.
Yes, ma'am.
Attach the pads, analyze the rhythm, and attach the pads.
The shock is delivered, but now the rhythm is asystole. What do you want to do? So nobody is touching this. We need to check the time when the patient got arrested. Okay? So when you are giving the shock, you have to put the paddles, one at the apex. Shock delivered.
You clear. Deliver the shock.
Yeah, shock
delivered. Continue CPR. CPR. So I'm giving CPR. Is the pulse resumed?
No, madam, it is asystole now.
So I continue CPR 30 to
I'm on A, B and C.
high quality CPR.
So you need to check the, now the patient has arrested, they have given a shock and airway. You want to secure the airway with an ET tube?
Yes, yes.
Yeah. You secure the airway with ET tube?
Till the time we continue with CPR, 30 to 2. Once the tube is inside, we can give 100% oxygen, 50 liters per minute.
Yeah.
So tube is secure. Now give 100% oxygen and continue CPR. I will exchange the role. Now the first person will give CPR. You can also give.
So now 3 minutes are over. Madam, 3 minutes over. And did anybody secure the IV line and give adrenaline? Yeah. Secure the, how much adrenaline you will give? 1 milligram of adrenaline followed by 20 ml of normal saline. That is the chasing liquid, chasing fluid. So where will you secure the IV line? In the upper rings, above the diaphragm. Right? So they have secured the IV line, they have given adrenaline 1 ampule followed by 20 ml of normal saline, and they are continuing the CPR. Still they did not get any rhythm on the ECG. ETCO2 is also not adequate. If the ETCO2 is not there, you need to push hard and push fast. Okay.
ETCO2 should be 10 if you are giving effective CPR. So just monitor ETCO2 also. Now it's increasing.
So adrenaline was given 3 minutes back.
You can we are repeating adrenaline.
Okay. Do you want to alert the obstetrician about perinatal cesarean delivery?
Yes. Now 4 minutes are over.
3 minutes over. Second dose of adrenaline given.
Now we should arrange for PMCD because after 4 minutes there will not be survival. So gynecologist, obstetrician, come on.
So which injection you want to give, sir? Whether it is a panel steel or SUM? Okay. Okay. So if you are comfortable with vertical, you can go for SUM. Otherwise, if you are comfortable only with panel steel, you can go for panel steel. Whichever you are comfortable with. The thing is, which instruments do you need? Excellent, sir. So sir has used only one scalpel and he has used two. Yeah. Now,
Continue CPR. Interrupt CPR.
yeah. So any oxytocin drugs to be given, sir?
Immediately, yes. You can give oxytocin and no other oxytocin.
Snort can. How much do you want to give?
Routine 10 minutes intramuscular.
So you want to give 10, ask them to give 10 units intramuscular? Yeah. Oxytocin 10 units intramuscular given, sir.
Just hold the uterus tightly to prevent bleeding from the uterus.
Now madam, do you think the RCO dogs has been come?
If the ROX is achieved, then
Is it achieved or not? Again, so after the oxytocin, the patient went into asystole again.
then there is no point in giving defibrillation. We continue with CPR and adrenaline.
Right. So another 3 minutes over, second dose of adrenaline given.
We continue with adrenaline 3 to 5 times. If it is not responding, then we can think of amiodarone. So load amiodarone. 300 milligrams time. Given.
The rhythm is not there, madam. Shall we wait to give amiodarone? We'll repeat adrenaline. 3 minutes over. So this is the third dose of adrenaline. So we are repeating. It's 10 minutes in CPR. Yeah, the patient is getting the rhythm. But ETCO2 is not there. So push hard and push fast. The rhythm is there, so you need to push hard and push fast for this patient to recover and come into the normal sinus rhythm. She is pushing hard and pushing fast. Okay?
How to do it? Give high quality CPR. Just your elbows should be straight. Then lock the fingers and 2 fingers above the end of the
sir, now what do you want to do? Shall we shift the patient to the OT?
Yes, I think first you have to close the uterine incision as fast as possible and just close the abdomen and then shift the patient to. You can do it there only now that you have opened it and shift the patient to ICU better.
After circulation, if you have acute circulation, she may bleed again. So you have to keep a watch on PPH.
Anything from your side? Okay, they are closing the uterus. Then you want to give it. You got another 1 hour. They want to take 1 more hour. Patient is bleeding.
Basically, you have to avoid, see that there is no bleeding, that the blood pressure is there, and just close the abdomen as fast as possible. You may think of keeping a drain, catheter is already in place, and shift the patient to ICU.
Yeah. Congratulations for making the patient giving her new life.
Proper timing of adrenaline. Proper timing and judicious use of adrenaline.
Yeah. The baby was linked. What was the name of it? So the thing is, yes, the cardiac arrest situation, as I said in the morning, 32,000 fortunately rare, but when it happens, things have to go precision. And the best person, the team leader is the anesthesiologist, because at the end, he can monitor, he can oversee, he can foresee everything and can take a time block. Time block has to be maintained. So if you see this patient went into VTAC for almost 3 minutes, but shock was not delivered. The shockable rhythms, 2 shockable rhythms, VTAC, VF. So if you look at the algorithm of VLS, if the patient is unresponsive, like patient who was talking, breathlessness, suddenly she becomes unresponsive. So the first and foremost step is shake and shout. If it is unresponsive, second step in CT of chest compression is ineffective. It reduces by almost 68%. So we want push hard, push fast. At the same time, do not compromise on the quality chest compression. So the best way to give aortic compression, relieve aortic compression is lift the uterus and if you can demonstrate this side or left side, manual left uterine displacement. So BLS in pregnancy is MLUD. It is very, very important step. So it is very important. You can give MLUD with 1-hand technique, 2-hand technique, without interfering.
Don't simply see, either we put a wedge like this, okay? Yeah, okay. Under the right hip, you put a wedge. So if you put a wedge, the patient will become like this. So the CPR, since it is not okay. So if you put a wedge like this, the entire patient will become on this side. So when you are giving CPR, it won't be in the middle. And the way you give the compression also, it will not directly fall on the heart. So that is why nowadays they are saying no wedge. But then it is manual left uterine displacement. So when you are doing a left uterine displacement, you pull the uterus up and push it towards you. Okay, push it towards this side. Okay. So that you may wonder whether can we do it, but you can easily do it. Okay, so usually how we teach our postgraduates is whenever the patient is given a spinal, whenever you are going to give an incision of the uterus, before that you manually displace the uterus towards the left side. That way you will be comfortable when because we rarely encounter a cardiac arrest, maternal cardiac arrest. So at that time, if somebody says manual left uterine displacement, it
it may become difficult for you. So every time when you are doing a cesarean section, it is useful for the patient also that you are giving a left uterine displacement, and you will also be comfortable giving a left uterine displacement.
So testing is two-hand technique wherein you just tilt it, or you one hand here, one hand here stabilize, and then lift and push it on one side, or so that you are not coming in the way of the person or giving the CPR. You are standing at the leg end and you are trying to give displacement. Otherwise, from the right side also you can just stand there and you can just displace the uterus to the left. Because we know that aortic cable compression can reduce the preload by almost 30%. So by relieving ITC compression, you can improve the preload and you can achieve early ROSC. So BLS in pregnancy is 30:2 chest compressions and manual left uterine displacement, which in cardiac arrest is not recommended because we don't want to compromise on the quality of chest compression. Now, how do we know that we are giving high quality chest compression? How do we know that we are giving high quality chest compression? ETC okay. So, if you have not purchased defibrillator, please purchase a defib with ETCO2 port. In fact, now it's a current recommendation. So always see that you have an end-tidal carbon dioxide incorporated in your defibrillator. And if you put a pulse oximeter probe, every time you give a chest compression, you should see a 70 figure. 70. You should see a good plethysmograph, good wave pattern. That means the chest compression is effective. That means the compression of heart between the sternum and the vertebral body is effective. And chest recoil. So 1 and 2 and 3 and 4. So give 100 to 120 chest compressions a minute and at least 30:2. And once you put a tube, then you give 10 to 12 breaths per minute, tidal volume breaths, and 100 to 120 chest compressions. And very important that one person is making a note of time. Like in this case, the patient initially was in VTAC rhythm, but shock was not delivered. And subsequently patient went into resistor, non-shockable rhythm. So, shock. So how do you want to give a shock? Whether you want to reduce the shock because it affects baby. So how do you monitor fetal heart rate during cardiac arrest situation? With ultrasound or with CTG? Do not monitor fetal heart rate. It is you. Salvage mother is important for us. So putting transducer, putting an ultrasound to check fetal heart rate, you are going to compromise on maternal chest compression. So do not waste time in futility. There is no need to monitor fetal heart rate during maternal cardiac arrest. Just concentrate on good effective chest compression. Push hard, push fast, 100 to 120 times per minute chest compressions, and every 2 to 3 minutes IV adrenaline if the non-shockable rhythm. A shockable rhythm, give defib, shock every 2 to 3 minutes, and 4 minutes if you cannot achieve ROSC, reversal spontaneous circulation. As our obstetrician was very effective, he just took a knife, refractor Alice and delivered the child. Very, very important. You are delivering the child not for fetal survival but for maternal ROSC. Because what is the advantage? Why do you deliver? Why do you deliver?
Increase venous return.
Huh?
Increase venous return.
Increase venous return in what way?
By decompression. Pressure. By decrease pressure on the.
Relieving the pressure in aorta, yes. Secondary. Exactly. 30% of cardiac output is in the uterine cavity. 30% of cardiac output. So the moment you deliver the child to the fetus, the outer transfusion occurs, and you lift the uterus and just hold it. Put green armitage at the angle so that there is no bleeding. Just lift the uterus, and then you can achieve ROSC very fast. So, 4-minute incision, 5th minute delivery, and continue ROSC at the site of cardiac arrest. There is no need to take consent in this situation. What if the obstetrician does not do cesarean section or perimortem delivery? मुझे नहीं करना है, patient मर गया है. You revive the patient first. It has happened many times. What do you do? not doing perimortem cesarean delivery is a culpable homicide. It's a culpable homicide. If you do, patient does not survive, you will not be liable. But if you do not do and patient does not survive, you will be liable in the law of court. Because perimortem cesarean delivery is a part of ACLS in pregnancy. That means you have not done proper ACLS by delivering the child. There is pregnancy beyond 20 weeks of gestation. Before 20 weeks, there is no role of pain because of the heart VFX. Okay? This is very, very important. That means 20 weeks is just umbilical height of the uterus at the umbilical side, umbilicus. It is very important that PMCD should be done at the site of cardiac arrest within 4 to 5 minutes, and baby has to be out. And importantly, the incidence of atonic PPH following cardiac arrest is very high. Because what is the cause of cardiac arrest? Sepsis can cause atonic PPH. Amniotic fluid can cause atonic PPH. Hemorrhage itself is because of atonic PPH. And some of the drugs also can cause hypotonia. So at least 50 to 60% of etiological causes can cause atonic PPH. And the conventional management of atonic PPH of this patient, who was almost willing to VTAC, again became historic after. So judicious use of oxytocin following ROSC is very, very important. And this is where our EOA guidelines mentioned, because if you look at the American Heart Association guidelines or ERC guidelines, this point probably because they have not got many experience in scenarios, but giving high dose oxytocin 10 units bolus, 5 units bolus, or 10 units per hour infusion in a depressed myocardium just had been revived is lethal. So use your uterotonics judiciously. If it is atonic PPH and you have delivered the child, go for compression sutures, go for balloon tamponade, go for whatever the other modalities. But see that the pharmacological usage is judicious. Okay, very, very important. So use of uterotonics in a depressed myocardium has to be very, very careful. Second thing is, we have replaced the term of perimortem cesarean delivery in our guidelines RUI, resuscitative uterine intervention, because some of them they require internal ligation, some of them they require revascularization, some of them they end up with peripartum hysterectomy also. It's just not perimortem delivery. So series of intervention can happen, radioembolization can happen, so a series of interventions can happen as a part of resuscitation. So in AOA guidelines, our Association of Obstetrics Emergency guidelines, we have replaced the term as PMCD as RUI, which is a bundle of measures that can happen. Little differences. So, but it's very important that BLS is different, ACLS is different, 4-minute code is different. Once you achieve ROSC, do not let go or use uterotonics judiciously. I'll give you one more scenario we have had, like you have a placenta percreta patient with hemoperidonia and cardiac arrest. What do? You have achieved ROSC, when the patient's cardiac arrest, there is no bleeding. Okay? But you have achieved ROSC, but patient is still, again going back to history, so surgeon is not keen to operate because of, in great time she is helpless. He says, if I do surgery, she is going to bleed again. We have encountered this situation, we incorporate this also into the guideline. So, when the patient is pulseless and cardiac arrest, there is no blood loss. But once you do perimortem cesarean delivery, there is a possibility that patient, once you achieve ROSC, and it can be double geocardy. You have achieved ROSC, but again patient starts bleeding. So that is where we have recommended the availability of vascular clamps or the maneuver of manual compression of aorta in this situation, so that you achieve ROSC, the patient is bleeding, you can arrest bleeding. So availability of vascular clamps, again Kylie's vascular clamp, you must have heard and you must have used it. It's very, very helpful device. Just clamp the aorta intrarenally and you can salvage lives. Don't worry about the spinal cord perfusion, your anesthesia is well versed with those things, but it is more important to save the life first. Okay? So these situations are very uncommon, but we have had unfortunately these experiences. of using vascular clamps as a part of PMCD, and that's what we have incorporated that also as a part of extended guidelines. So a few things which you have to remember is, do not compromise on chest compression, push hard, push fast, BLS, do not forget MLUD, ACLS, do not forget PMCD or RUI, and continue resuscitation. When do you want to abandon resuscitation? Continue at least for 2 to 3 hours. Do not abandon, because we never know. At least sometimes if you are giving it, the quality of chest compression is good, the cerebral perfusion also is maintained. So what we have is CPR, CPCR. We want to give effective cardiopulmonary cerebral resuscitation. We want to have a mother with good neurological outcomes. And while post ROSC, when the surgeon is doing completion hysterectomy or completion hysterotomy and closure, see that you start organ protective strategies right from the OT, not from the ICU. See, many times what we are taught is, once the patient is shifted to ICU, organ protective strategies start. But organ protection has to start from OT itself. Because the patient is going to take another 30-35 minutes to be shifted. So, little hypothermia, lung protective ventilation, insertion of orogastric tube, and all these things have to start right in the OT. And as Dr. Sunil rightly said, monitor this patient closely post in the ICU, because it is very important that if the patient post cardiac arrest has seizure, it indicates very grave prognosis because the diffuse cerebral damage. But suppose if there are no seizure in first 24 hours, good prognosis.
Sir, can you tell us adrenaline dose?
Adrenaline dose, every 1 milligram, 2 to 3 minutes. There is no ceiling. But importantly, whenever you are giving adrenaline, imagine that you are giving adrenaline in a patient with static circulation. So when you are pushing adrenaline, run at least 50 to 70 ml of saline, so the adrenaline reaches myocardium. And other important aspect, Dr. Kausalya was insisting during her this thing, venous access. Obtain venous access in the upper limb. Do not obtain venous access in the lower limb. The very reason is, we don't want the aortic valve compression to compromise. Whatever drug we are giving should go to the myocardium. So if you are giving infradiaphragmatic venous access, drugs may not reach. Dilution, because you can give undiluted, but only the important thing is push at least 50 ml of saline following that, or give a running infusion and just push it, because dilution is there in anaphylaxis. If you are giving an anaphylactic shock, you take 1 ml of adrenaline, make it 10 ml, give 0.2 milligrams, like 1 to 0.2 milligrams intravenously. And in an anaphylactic shock, if you don't have intravenous access, you can give intramuscularly. A subcutaneous is going to take time. Intramuscularly can be given.
Some of the societies, they advise adrenaline to be diluted to 10 ml for all cases, just to avoid the confusion.
In ACLS, they say that you have to directly give.
You can give directly, madam. You can give directly, but see that the free fluid is running. Again, norms and lingual active, there are no dextrose in CPR or any of the situation. So, adrenaline dosage, 1 mg. Yeah, raise the hand, yes. Once you give the drug, raise the hand, so that basically you want to aid the drug to go to myocardium. So, give adrenaline, raise the hand, then 30 to 50 ml of saline, and do these things. And if it is VF, VT, do not lose that opportunity to give a shock. The incidence at the shock capacity or the thing is same, 200 joules. If it's a biphasic defibrillator, so monophasic can go up to 350 joules, but monophasic we are not using now. Biphasic defibrillator start with 150, end up with 200 joules. You can give a shockable rhythm. You give 2 shocks. If it's still persistent refractory VT, VF, as Dr. Sunil said, yes, you need to give amiodarone loading dose 200 milligrams and look for causes. So while ACLS is going on, A, B, C, D, E, UPS should be going on in your mind. What am I dealing with? And see that you give targeted therapy. Targeted. Suppose if it is a cardiac arrest because of magnesium supertoxicity, just give simply calcium gluconate. 2 grams should suffice. So it is very important that you evaluate the cause, 5H, 4Ts or ABCD, UPS. You know 5H and 4Ts, right? Hypoxia, hypotension, hydrogen ion excess, and hyperkalemia. So hyperkalemia treatment again is bicarbonate calcium gluconate. And T's are 4 T's are tension pneumothorax, tamponade, pneumothorax and toxins. So toxins fortunately are rare in pregnancy, but we still have seen a couple of hormonal process poisoning in pregnancy also, not related to the cardiac arrest, but yes, they do happen. So you need to keep these things in mind. Okay.
So there was one question from the audience whether we need to take a consent for doing a perimortem.
No, I told that there is no need for consent because it is a life-saving surgery you are doing. Okay, I'll give you one more example. This is the case that has happened when I was at Care Hospital in Visakhapatnam. We had gone there for some time. A patient who was antepartum hypertensive crisis and has a massive intracranial bleed. Massive intracranial bleed and is brain dead. 24 weeks pregnant. Fetal heart is good. But she is brain dead. What do you want to do? You want to continue ventilation like support till the fetal attains viable age? Or I'll give one more example. This case also we have had. Traumatic brain injury, brain dead mother, fetus is in good condition, 22-23 weeks pregnant. So these are all ethical dilemmas. Nobody has a definite answer, and that is where you need to have an ethics committee or involve magistrate early in your this thing so that you can take appropriate decision. Many a times, if the patient is brain dead, certified by third party, not by the same team, certified by non-treating team members who are qualified to certify brain death, and they are the best donors for organs, mother, because they are young, no other problem. But I'm talking about other side, flip side. If you cannot revive the mother, but they have the best young, healthy organs, and they are good for organ donation.
But
And
have there been any cases where mothers have been conserved and after 24 weeks they have gone further into
yes,
and they've had a good fetal outcome?
they have had a good fetal outcome, but brain dead mother and organ donation also was done.
And so just
Continue till the fetal viability, because the husband wanted the baby as a memory of his wife, and the parents wanted organs to be donated, mother also. So there are quite a few case reports where the pregnancy has been prolonged till viable age and subsequently the organs have been donated. But those 4 weeks of maintenance, you have to have the best ICU condition because you don't want to give any VAPs and HAPs and classes and 40s and all those things. So you need to keep those things in mind. But I'm just trying the other side of the scenario. So it is just not simple CPR. You need to think beyond CPR. Okay. So any questions so far?
Sir, in case of organ donation, how we can avoid post-mortem examination which is required in that?
That's what. Actually, this is there's an involved magistrate. So that there is no medical legal suspicion of any of those things. We had one case at Hyderabad, also there, you can remember. A beautiful case actually. This patient comes pleading with severe headache, pleading for pain. Sir, kuch karo, sir, fata ja raha hai. BP is 140/90, urine albumin is 1+. The patient is a booked case, normotensive, low risk pregnancy, and there is single lady at admission now with 140/90. Obstetrician comes, shift the patient to ICU, says, we have given 1 gram paracetamol. Sir, cesarean section telling she is having Eminent eclampsia. And she says, kuch karo, I am having severe. So what type of anesthesia you want to give to this patient? Preeclampsia profile is normal. Urine albumin is 1+. GCS is 15. What type of anesthesia you want to plan for this lady? She is for cesarean section. Platelet count is normal, 1.8 lakhs. epidural, regional, GA, huh? Fundoscopy is normal. See, this is what I want to convey. Just because obstetrician has said cesarean section karna hai, and we start thinking whatever conditions to be given. Why is this lady having severe headache? And do a thorough examination, and we found she has having 6th nerve palsy, which is not there. GCS is 15. She is pleading for pain relief for headache. 6th nerve palsy is there. Now you tell me what kind of anesthesia you want to give.
Now we don't know because it requires to deliver.
6th nerve patient. So what do you want to do then?
We can induce. Yeah, we can induce.
See, this exactly. 6th nerve palsy, severe headache, fetal well-being is good. Why don't you get an CT scan done? Lower intracranial pathology. So, we got a CT scan done and there was a bullet in the brain. The husband shot through the nostril. And smart fellow, and subsequently when we saw this bullet and we saw there was an entry point which we read in forensic. Entry point was there was a little bit of abrasion at the nose, but that was only in retrospect we could diagnose. So the husband and the entire in-laws wanted her to die during surgery, during anesthesia. Huh? They had some dispute. And she didn't want to give and probably, I don't know, sometimes what happens is you are also, okay, something of that sort. But fortunately she came to us and we got a CT scan. We did a craniotomy, evacuated intercerebral, subdural hemorrhage, and then we did cesarean section. Both survived. Both of them survived. And we could salvage the marriage also. But what I want to emphasize is, just because cesarean section, when you find something abnormality, question yourself. Okay, what category cesarean section is? Suppose it's a category 1 cesarean section. And that will rectus palsy. I will give GA. And I will not extubate this patient. Straight away, following GA, I will transfer her to a CT scan or MRI, get a CT scan done, and then plan for extubation. So certain basics you should be very, very well grounded. Like when to do, what to do, when to grind, what investigation to be done. If the patient is hemodynamically stable, go for MRI, brain with MR venogram. If you are suspecting intestinal pathology. If you feel patient hemodynamic unstable but you are suspecting intestinal pathology, get a rapid CT done. At least gross pathology. So this is what just few tidbits, but any doubts in the morning, we can plug it before we move on to the institution therapy. Kaushal, you want to see? Yeah, you can. You can ask.
Actually, we have done with all the 4 scenarios. You can either have one more scenario or you can ask your doubts. Which one will you prefer?
I think it's better to have an open house discussion. One more scenario.
Okay. Third scenario. We'll run the third scenario.
Okay, so dry the back. After you finish drying the back, the next step is warm, dry, stimulate. So stimulation, historically we've done all kinds of things to babies, slap them, pinch them, squeeze them. None of these are validated now, only 2 methods to stimulate. Either vigorously rub the back or flick the soles twice. That's all. Do any one method, do it once and move on. Don't keep stimulating this baby. So once you stimulate the baby, so once I prefer rubbing the back because I'm anyway drying this portion. So stimulate. After stimulation is done, the next step is position. During these 3 steps, we have moved the head around quite a bit. So we need to place the baby back in supine position. Keep the head in neutral position. We don't want it hyperextended, we don't want it flexed. Neutral position. So this is position. And then we suction the baby. What do we suction first? Nose or mouth? Mouth first. Remember M before N in the alphabet. So mouth and then nose, because there's a large volume of saliva in the mouth, which if you suction the nose, they're going to aspirate and gas. So that is suction. So warm, dry, stimulated position, suction. We finished our initial steps of resuscitation. 90% of babies will respond just to these initial steps of resuscitation. Only 10% will need something beyond this. So after you finish this, there are two things to assess in this baby. We are going to assess the breathing of the baby, and we are going to assess the heart rate. Okay? So always have the earlier system of pulsating, the pulsations of the cord are now outdated. Everyone recommends carrying a stethoscope, so we must check the heart rate of this baby and breathing. So if there's a need, you can always use it. This for the cost of about 8,000 to 10,000. Not very expensive.
So can we get the brochure?
Yeah, it's from Vigon. No, this patient is breathing spontaneously.
In that case, if we stop them before intubation sometimes.
Ambu-bag means you have to breathe for the patient. Ambu-bag you have to breathe for the patient. So basically you just have to fix it. And this is you have size. If you have size 3, size 4, depending on the face. But generally,
Can you see? This is glottic. These are vocal cords. And you can put it in this is channelized. So through that channel under vision you can aspirate. Okay? So when you are giving breaths, there we have the airway station. You need a difference unless otherwise you move the jaw forward, the tongue will fall back. So if the tongue falls back, you can't give the respiration. So this is the C and this is the E. English letter E. English letter C. Okay. So this is C and this is E. Right? C. This will have a triangular shape. The lower part will fit into the jaw. This is the jaw line. Okay. And this is for nose. Right? We should not put like this. Okay. No, we put like this also. When we listen, it's like this. And this is the C. Right?
very excited. FDA approved device. And I just spoke to the person here. He said that the usage of sticks is more that the device will be.
Hello. After 2 minutes, please go in the clockwise direction
is,
to the next table.
Like how you check urine albumin at the time of admission or lipstick proteinuria, you can make it a normal, regular norm, so that instead of sending to the lab, you can just do point of care testing. And if the patient bleeds eventually, for some reason, or instead of sending CBC daily, you can just do point of care testing. It is very good.
Congestion.
ED matters. So you should be careful. But yeah, it is smooth and non-traumatic. And you can always put Dr. drops. And then put the. So, हे तुम्ही आता सगळे स्टेशन्सला जाऊन then you can do hands-on. This is
breathe, then you have to go for ambu-bag and CPR and all those things. And other thing that I wanted to impress upon you is, of course, you don't have to learn the skills of intubation, but that is a wonderful device, video laryngoscopic guided intubation. If you look at the difficult airway guidelines from or difficult airway guidelines from DAS UK, they recommend that the first intubation in pregnancy should be video laryngoscopic. Because when compared to non-pregnant women, pregnant women coming for surgery, cesarean section or whatever procedure during antepartum period, the incidence of difficult airway is 10 times more than
big position, that is head extension and then chin lift. Okay, so the jaw thrust is a maneuver where when the patient is unconscious, the jaw falls back. It will be like this. Okay, so you have to thrust the jaw forward.
That is the moment. That is the moment. Okay. If all the tongue muscles, they get attached to the jaw. So when you are pulling the jaw forward, you are pulling the tongue forward. Okay. So this is the moment you have to do. That is jaw thrust. Chin lift, neck extension, and jaw thrust. That is known as a triple maneuver. When you do that, the position will be like this. And then this is the B, this is the jaw end, and C and E technique, and then give 2 breaths. If you can't do this, because you are obstetricians, you can't do, you can continue with CPR, but put some kind of oxygen on the face. Okay, right? So that is known as compression on the CPR. So how to do the CPR? How to do the effective CPR? As I already told you, somebody has to do the manual left displacement, and then in the mid-sternum, with the dominant hands, from this part, in the mid-sternum, and then give a compression. So mannequins are made in such a way that they produce a sound when you do a current compression. Okay, so that is the rate, 5 centimeters. Okay, right? And the rate will be 100 per minute, 100 to 120 per minute. So how will you know it is 100 to 120 per minute? That's why we need to count 30 and then 2 minutes. If somebody has intubated 6, so I am going very fast. There is no recoil. So I have to know that there is some recoil. So the manometer is 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000. So when I am counting the 1,000, I am allowing the recoil. Okay, so even the 1 and 300 is also not allowing that much of recoil. Okay, so if you do 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 7, 1,000, like that, up to 7 you can count 1,000.
After inserting or after inflating?
No, after inserting only. Once you get click, then only you inflate. तोपर्यंत करायचंच नाही. हा दाखवतो.
बरोबर तिथे जाऊन
इतकं सिंपल आहे ते.
आवाज नाही येत ना?
आवाज नाही, क्लिक म्हणजे तुम्हाला तो तो असा फिट झाल्याचा. सी काय होतं, बेस ऑफ टंग
स्टोर्स सगळे आलेत आज लागले.
Ideally you should have, it is like laryngoscope. This we use as a teaching tool.
Please change after 1 minute.
Have you seen? Far high, 80,000 Can you see vocal cords? These are white vocal cords. This love? Yeah. You can put tube. So there is a channel.
Keep the lungs little inflated at the end of expiration, and that is where the beauty of CPAP mask is. Basically, CPAP is nothing but
stimulate, position, and suction. Okay, so I'll just see them again. Warm, dry, stimulate, position, and suction. They have to be done in this order. How do you warm the baby? You place the baby under a radiant warmer which has been... Yes. How many babies do we have? Singleton, twins, triplets? Second is whether this is a term gestation or a preterm gestation. Third is it like a meconium state or clear? Fourth is are there any antenatal risk factors? If once you've asked these questions, single pediatricians, so there's no question of assigning roles. Bigger setups, big team of resuscitators are around. Assign the roles before the delivery itself, so there's no chaos. C is checking the equipment, the most important step. We'll deal with the equipment as we're doing in the algorithm, which will be 10 minutes. So once you finish these 3 things and your baby is delivered and brought to you in the delivery tray, what is the first thing we look for in a baby generally? So normally you listen to cry. No? Most of us are interested baby has cried or not. There are 3 things to check actually: term, tone, and cry. So we have to look at the baby and decide if this looks like a term baby or it looks like a preterm baby, because immediately you know what you're going to use. Second is tone. Most babies have a slight flexed posture. That is normal tone. Some of the babies will be limp. So that is abnormal. Third is cry. Most of us are very attuned to checking for cry. If the answers to all three are good, that means the baby looks like a term baby, has good tone, and the baby has cried, this baby will require only routine care, and then this will be shifted to the mother or the relative. So what is routine care? Ideally, routine care involves placing the baby on the mother's abdomen, turning the head to one side, drying the baby, suctioning the mouth and nose, and ongoing evaluation. For most practical purposes, because we don't have a sterile field or constraint of space, we generally perform the initial steps of resuscitation anyway. Now suppose the answer to one of these questions is negative, that means the baby looks like a preterm baby or the baby, so any of these things, baby is not crying, baby's tone is limp, you take this baby to the resuscitation area immediately and perform what are called the initial steps of resuscitation. Initial steps of resuscitation have 5 key action verbs. What are those? Warm, dry, stimulate, position, and suction. Okay, I'll say them one more time because they have to go in that order. Warm, dry, stimulate, position, suction. Okay, so how do you warm this baby? You place this baby under a radiant warmer which has been turned on a few minutes before the delivery in manual mode in 100% heater output, so that the entire area is warm. We dry the baby, of course, by keeping in mind the large surface area of the body. So we first dry the head, then the trunk, then the limbs, and never forget the axillae and the groin because they remain wet sometimes. Then turn the baby to one side and don't forget to rub the back also. Okay, that's also important. What comes after warm and dry? Stimulate. Now there are, historically we've done all kinds of things to babies, squeeze, pinch, hit, slap, hold the baby upside down. None of these are validated. You need 2 validated methods of stimulating a baby. Either you rub the back vigorously or you flick the sole twice. Pick any one method, do it only once and move on. The temptation is to keep stimulating the baby, imagining that he'll cry and then start breathing. Do it once, do it properly, and then move on. So warm, dry, stimulate. What's next? Position. Because in the process of warming, drying, stimulating, you move the baby around, the airway tends to get closed. So now keep the baby in supine position, keep the head in neutral position, neither too flexed, neither too extended. Keep it in neutral position. And finally suction. Suction what? Nose first, mouth first. Mouth first, always mouth first and then nose. Any reason? Right? Yeah, so the large pool of secretions are in the mouth. If you tend to suction the nose, they'll aspirate it, like a big gasp and aspirate. So you suction the mouth and then the nose. And these are your initial steps of resuscitation. After you finish the initial steps, 90% of the babies will respond just to these initial steps. How do you assess the baby after initial steps? We check for 2 things, breathing and heart rate. Okay? Don't expect all babies to cry after this stage. They may just be breathing. So check for breathing and check for heart rate. The baby is breathing well and the heart rate is more than 100. Your initial steps are successful. Now what do? You hand the baby over. You just check 2 more things. You check for labored breathing and check for persistent cyanosis. Labored breathing is manifested by chest retractions, nasal flaring and cracking. So if you have labored breathing or you have persistent cyanosis. By cyanosis I mean central cyanosis around the mouth. I'm not talking about acrocyanosis. Okay, hands and feet may be a little blue, that's okay. But if you have labored breathing, if you have persistent cyanosis, then you're going to, what will you do for this baby? You will provide oxygen. Just provide oxygen for 15 to 30 minutes and then reassess this baby. You can provide oxygen either by oxygen by hood, you can give oxygen by nasal prongs, or even simple blow by oxygen. Okay, just by holding above the baby's face. So, but now coming back to the main algorithm, after your initial steps, if the baby is not breathing or the heart rate is still less than 100, now what are you going to do? Now you will provide positive pressure, 29%, a further 9% will respond to this. 1% will require intubation and chest compression. Okay, while giving positive pressure ventilation, remember we need either a 250 ml bag or a 500 ml bag. This is the 500 ml bag. And you need 2 types of masks, term mask and a preterm mask. Okay. All the masks in the units are face around shape, not face shape. Okay. What is an ideal size mask? When you place the mask on the chin of the baby and keep it like this, it should not cover the eyes. Okay? So we don't want it going beyond the chin, we don't want it covering the eyes. That is the ideal size of your mask. Okay. How do you provide positive pressure ventilation? So there are 2 techniques to remember. One, EC clamp. What is EC clamp? This is how you hold the mask to the face. C is formed by the thumb and index fingers, which we use to press down upon the mask. E is formed by the last 3 fingers, which we use to pull up the ramus of the mandible. When you're doing this, don't inadvertently push the soft tissues of the neck inside. So you hold the bony structure, don't push the neck inside. Okay? If you push the neck inside, tongue will fall back and compress the air. So EC clamp, C will be pressing the mask down, E will be putting the mandible up. Okay? How do you provide the breaths? What is the breathing rate of a newborn? 40 to 60 per minute actually, for which we are going to provide here. How do you provide 40 to 60 per minute? We use a rhythm used universally called breathe 2, 3, breathe 2, 3, breathe 2, 3. So when I say breathe, I am squeezing the bag. When I say 2, 3, I am releasing the bag. So don't do breathe 2, 3, breathe 2, 3. That will become 90 per minute. So breathe 2, 3, breathe 2, 3, breathe 2, 3. You do this for 30 seconds and reassess the baby. Okay. So at the end of 30 seconds, now you will assess only one parameter, that is heart rate. Now we don't even bother checking for breathing because you have given the breathing. Okay. So you check the heart rate. If the heart rate is less than 100, then you need to proceed further in the algorithm which involves ventilation corrective steps. If you don't get chest rise, then there are some steps which are called ventilation corrective steps. We also have a mnemonic called MR SOPA. MR is mask readjustment, means you lift the mask and then reposition it here. Reposition the airway, that is MR. Okay, try again. Now if you get good chest rise, continue doing this for 30 seconds. Suppose even with this you are not getting chest rise, then what are you going to do? MR is over, SO is next. S is suction again. Again you suction the mouth and then the nose, and then open the mouth and try again. Okay. Despite this, if you are still not getting chest rise, then comes P. What is P? Pressure. You increase the pressure of the random bag. Okay. So try and squeeze it a little harder and see. Okay. If that gives you chest rise, good enough, then continue for 30 seconds. The last step is A, which is alternative airway. Now you are going to intubate this child. So intubation is always last resort after you finish all this. After doing all this, if you've got good chest rise and you've given for 30 seconds, you check for whether there is effective chest rise and you check for heart rate more than 100.
This can be attached to the positive pressure. Yeah. So this just have to attach to the flow, oxygen flow meter. Attached to oxygen flow meter gives 50 liters of oxygen. This mask is attached to the oxygen flow meter. Simple oxygen flow meter gives 50 liters of oxygen. It gives a CPAP of 7 centimeters. So there is something with HF in this is better. So medical legal ambu bag ventilation.
All attention to the stage, please.
So why we have this now, that this mask, how it will ventilate the peripheral alveoli which you are saying. So only this mask, how is it working? Pressure oxygen. Yeah, oxygen is connected, but oxygen just going from here.
Good. Just 2 minutes. Can you please give me 2 minutes? Dr. Pandya, can you come for 2 minutes first? We would like to acknowledge the presence of Dr. Mandakini Lake. She is the president of Association of Medical Women of India. She was here for the function and happy that ma'am is here. Thank you ma'am for making it.
This doesn't have the airway.
I would also request the volunteers from the medical college. Can the volunteers from the medical college, the residents, come and take a small appreciation from us? Please come. All the residents from the medical college who have come as volunteers today, please come. Please come forward. All volunteers from the medical college, you have been a real help. Okay, 1 minute please. I want to congratulate Dr. Gauri Karandikar, a very favorite intensive student, colleague. Now on par with her. We are both seniors now. And most importantly, I have been the president of Association of Medical Women of India. He is my very favorite person in the Nashik river and the regional, I can say, in charge of the Nashik river. Also, I was the ICD chairperson from 2021, and you people must have done the FICD. Most people have not done the FICD. Please fill your form, list to be short. And last but not least, I am contesting for the post of President Foxy. I have done so much for Nashik and for Maharashtra. I am 100% sure that you are going to support me for my presidential position. Thank you. One minute. So we would like to felicitate the youngsters who are here with us. They have been. Can I call upon stage Dr. Vaidyanathan Chaudhary and Dr. Shwetal Bora, who are anesthetists who have volunteered today for Shwetal Bora. Please come here.
Wait. Yes. Thank you.
I would request Pandya sir to please felicitate our anesthetic volunteers who are here today to help us.
Madam, एक मिनट थांबा. Group photo.
Can I also request Dr. Kopikar? He was not there for the installation. Dr. Kopikar, please come. We wanted to felicitate you. He is managing our workstation. Dr. Kopikar is at the NDMP Medical College. He has done his DNP in neonatology and fellowship in neonatology, and he has been managing our workstation today. Thank you so much for coming here. You can leave it there.
Wait. Thank you.
Sun Pharma, Senora Spectra Division, thank you for being here with us and supporting us for this activity. It has been nice. Can you just take it on behalf of your team? And before we have this closing remark, I think Sir wants to have a few words. I will give him the last one.
Again, all good things have to end. Time for us today. So I profusely thank Dr. Gauri and her entire new cabinet or new team for giving us this privilege of conducting this workshop. I don't know how much benefited, but we enjoyed. I would especially thank the entire Foxy team from Nashik for giving us this opportunity. And I thank all the vendors, Mayur from Bridal, Charmi from Carl Stores, and Vicon for giving CPAP mask and Ambu, and yes, Amit Singh is here, Charmi is here, Bridal Mayur. Thank you very much. Thank you very much.
Workstation will continue. They have to leave for their flight. So, we are finishing the thank you before, but we will continue with the workstation.